imaging to capture where exactly lesions are. And so in terms of 3D imaging, as I mentioned, you can reconstruct it in any plane you want. And this is an example where we basically flatten the image with a curved planar reformat to look at both MCAs in one image. And then on the lower row, you can see you can really manipulate the imaging to best look at the artery in a perpendicular plane relative to its course. The DANTE is a pre-pulse that I mentioned earlier that's really good for suppression of blood signal, and it also suppresses CSF signal. And we've had a few publications highlighting that its ability to do that relative to native acquisitions. But it's a very valuable pre-pulse that you can use for this purpose. So in terms of imaging acceleration, as we know, if you get really high resolution sequences and acquisitions, it can take up a lot of time. And our initial 0.5 millimeter multi-contrast protocol took 70 minutes, which is not clinically feasible. You can't really do a clinical scan with a 70-minute acquisition. So what we've developed is a advanced partial parallel imaging technique that we call custom step, where we were able to take that 70-minute protocol and speed it up to 15 minutes. I mean, you can see here in comparing the images, there's not much loss in image quality or image fidelity between the fully sampled acquisition and the 4x accelerated acquisition. In terms of reproducibility of the technique, we published this paper maybe a couple months ago. But one issue is that there really isn't any guidelines in terms of how to evaluate disease out in the literature. Everyone's kind of doing it based on their experience and the learning curve they went through and what probably is versus what isn't a lesion. And so we decided to establish some criteria. And through an iterative process of review with 4 reviewers, some of whom had no experience with vessel wall imaging and some of whom had a lot of experience, we developed these criteria in terms of assessing whether there's no plaque, whether there's possible plaque, or whether there's definite plaque. If you guys need this, I'm happy to share it. And this is also, we were trying to establish these criteria based on looking at MRA, pre and post contrast T1 weighted vessel wall imaging. And we had these 4 raters, as I mentioned, with very varying degrees of experience. One person had never reviewed a vessel wall imaging study before we started this kind of iterative process. And what we found is that we got moderate to good agreement in all categories for inter-reader reproducibility, with agreements ranging for most arteries in the 80 to 90%. The main exceptions were the posterior circulation, and that was mainly because we had very few atherosclerotic plaques involving those arteries. So it was a very limited group that we looked at there. In addition, for interscan reproducibility, kind of similarly, we got moderate agreement in most categories, with the exception of the posterior circulation, which was a little more limited. And so now in terms of application to emergent stroke, there's not much in this space, and generally we're looking for expediency in terms of evaluation and triaging patients. This was an interesting study that was published by a French group at Rothschild. And what they've been using, they do MR for their stroke triaging, as a few places do. And this could be a consideration for an institution that's doing that. What they do is they do their DWI, they do their contrast enhanced MRA, but they also do this accelerated vessel wall imaging technique that's a 2-minute technique. You can see that everything is suppressed, except for, in this technique, those arteries that are occluded. You can see right here, there's this paucity of arteries in the left MCA territory, and that's exactly matching up with the area of enhancement. And just to superimpose the various imaging modalities, you can see right here, MRA was superimposed vessel wall technique. Those branches that are enhancing are all within that territory of loss of flow, in that territory of ischemia, with superimposition of the DWI and the MRA here. And here's another example, a patient with a small right insular infarct right here. And again, it's kind of tough to see the loss of branches within the right MCA territory. Again, here, that small right insular infarct here. And then somewhat tough to see that branch occlusion within the M2 branch, which we all know can be difficult sometimes to pick up. And on the vessel wall MR technique, this 2-minute accelerated low resolution technique, you can see diffuse enhancement throughout the branches downstream from that occlusion. And the reason this ends up happening is with occlusion of that branch artery, contrast can seep into the stagnant blood distal to the occlusion, and it just kind of sits there, and it results in enhancement in everything with stagnant blood flow within it. And this is a phenomenon we've seen historically on MR, but with vessel wall imaging, it really stands out more because all the other blood vessels are suppressed. So also in terms of intervention evaluation, there are a number of groups that have looked at post-intervention vessel wall imaging. And the first group is a group from UC San Diego, where they looked at 6 post-thrombectomy cases in 5 control patients. And they found that in the post-thrombectomy cases, all the M2 segments showed enhancement that were selected. 83% of the M1 and 50% of the ICA segments showed concentric vessel wall enhancement. And this is secondary to, as we know, you put a stent in, it's a traumatic process as you pull it out, and that injury can end up resulting in enhancement. Another study from the Toronto group, where they looked at 6 stent retriever and 10 TPA patients, again found a significant difference in terms of that enhancement and wall thickening in the thrombectomy cases. And the last study from a Korean group, where they looked at 15 endovascular cases and 14 TPA cases, they found a significant difference in terms of concentric enhancement, where the selected artery showed enhancement as compared to the TPA cases where there was recanalization. And that enhancement was associated with more passes and longer procedures. So the more traumatic the thrombectomy was, the more likely it was to enhance. In addition, it was associated with increased likelihood of hemorrhagic transformation. So the enhancement directly correlated with enhancement, or the hemorrhage directly correlated with enhancement, with an odds ratio of 11.18. So that could indicate the degree of injury and the likelihood of potential bleeding in that scenario. So in terms of differentiation, so this is an area of importance. This was we currently have a vessel wall imaging survey that we've put out to the ASNR membership, but we initially did it for just the vessel wall imaging study group members, looking at various questions. But one of the questions is, why is your institution performing intracranial vessel wall imaging? And the most common answer was for vasculopathy differentiation. So this is an area where, and at most institutions, it's the clinicians that are ordering it. And so it's in your guys' hands. The non-radiology clinicians are the one ordering it for the purpose of vasculopathy differentiation. Is this atherosclerosis? Is this vasculitis? Is this RCVS? Is this Moyamoya disease? Or this is atherosclerotic Moyamoya syndrome? Those are the questions that clinicians seem to want to know. So the first study we did was in stroke a couple years ago. And what we looked at was, we just wanted to characterize what these lesions look like on a multi-contrast vessel wall imaging protocol. And we had a total of 29 cases with 118 lesions, and we had 2 blinded raters evaluate each of these lesions independently. And what we found was that there was a significant difference in terms of the T2 signal characteristics, where atherosclerosis typically showed hypointense components, or hyperintense components, with its most common appearance being hypointensity with a juxtaluminal hyperintense band. Vasculitis typically showed isointense signal and concentric lesions, while RCVS showed minimal to no T2 wall changes. And just to show you what those appearances are, on the far image is atherosclerosis. You can see that hyperintense band along the lumen with the deeper hypointensity. Vasculitis shows that circumferential isointense signal relative to gray matter, kind of similar signal there. And RCVS in that region of stenosis, we really don't see much in terms of wall changes. Where's my arrow? There we go. See, there's the RCVS, not much in terms of wall changes. Vasculitis, isointense wall thickening relative to gray matter, and atherosclerosis, hyperintense band with deeper hypointensity. So in terms of the T1 signal characteristics, generally what atherosclerosis looked like was an eccentric lesion that showed outward remodeling and incomplete lesion enhancement. And the range of enhancement was very different for these lesions. Vasculitis was typically circumferential with complete lesion enhancement that was intense, and it didn't have remodeling. And RCVS showed minimal wall thickening with minimal to no enhancement. And just to point out, as we mentioned, about 9 out of 10 atherosclerotic plaques were eccentric. Vasculitis, more than 9 out of 10 were concentric. While RCVS was kind of all over the place because that degree of wall thickening was minimal. And so for that reason, you'd get raters going in all directions in regards to its evaluation. And here's just that appearance. We see the top row is a patient with vasculitis. You can see multifocal stenoses in that intense circumferential enhancement involving that ACA segment that's involved. For atherosclerosis in the middle row, that MCA bifurcation lesion, where you can see the lesion along the anterior wall of the artery. It's eccentric, it's outward remodeling, and it shows heterogeneous enhancement. And then the RCVS case in the bottom, in that segment that's involved, the left A1, there's not much wall thickening that we can see. The enhancement along the right A1 is actually periarterial venous enhancement. We imaged in coronal plane, that enhancement went away. So next we looked at patients who had concentric lesions, and we analyzed those specifically to see what characteristics would differentiate diseases. You know, if you got those 1 in 10 atherosclerotic plaques that was concentric, how could you differentiate it from RCVS and vasculitis? What we found was for atherosclerosis, you could differentiate it from the other diseases based on that juxtaluminal T2 hyperintense component, as that was present in 62% of those plaques. While it wasn't present in any of the vasculitis or RCVS plaques. And the intensity of enhancement differentiated RCVS from everything else, where RCVS generally did not enhance with these lesions relative to the other guys. And here's just an example. You can see a high-grade stenosis involving that left MCA, and this was one of the first vessel wall imaging cases I ever did. And you can see that concentric enhancement associated with it right here. And so the question is that vasculitis? Is that atherosclerosis? Is that something else? I was nervous because I thought, you know, this is going to make or break me if I make the right call. This is, you know, the first study I'm doing. All the neurologists are watching me. What am I going to say? And then you look at the T2 here, and oh, whoops, meant to push this button. On the T2, you can see that hyperintense component along the luminal surface and that deeper hypointense component, which we just described for atherosclerosis, right? And so I went with that, and I said, I think this is atherosclerosis more than likely. And they said, are you sure? You know, this patient has had 3 stroke events in 3 or 4 months. You know, there was involvement of the PCA territory and the left MCA territory. Are you sure this is atherosclerosis? And I was thinking, no, but I said yes. And so the patient was started on maximal medical therapy. An additional statin was added to the regimen. We sequentially imaged this person, probably because they didn't completely believe me. And we were doing imaging every 6 months. And at 1 year, you can see that same lesion has opened up. And you can see now it's much more eccentric in terms of pattern of involvement with decreased enhancement. As we mentioned, I don't think we mentioned it here, but I mentioned it to someone else. But over time, after stroke events, the literature indicates that there's progressively decreased enhancement as you get further away from the stroke event. So this all supported that this was an atherosclerotic lesion, and the patient has not had any subsequent events since then. So in terms of combinations, we found that the combination of T2 and T1 pattern of involvement really helped best differentiate atherosclerosis from the other diseases, and the enhancement differentiated RCVS versus the other diseases maximally in terms of accuracy. Now, what we have found is that there are some cases of RCVS which do show enhancement. Most of the time, it's pretty easy to differentiate. It's very minimal. It may involve, a small area, and it may not necessarily match with stenoses. I have had one case which really stood out, which I'll show to you in a minute. But in terms of the literature in regards to our findings and what they've thought, there have been a few papers published in this space, and they generally agreed with us. Vasculitis generally shows thick wall enhancement. in a concentric pattern that persists, and RCVS shows none to mild enhancement. That the stenosis resolves, and any wall abnormalities you see resolve as that luminal pattern changes. And here is a case where we did see a lot of enhancement in the setting of RCVS. And this is an interesting case because it's really the only case. Now we've collected about 35 cases of RCVS. It's the only case we have that really has this appearance. But you can see multifocal stenoses on catheter angiogram and on MRA reconstruction. And you can see all these branches just show diffuse enhancement here, right? Throughout actually all the vasculature in this patient. And it's interesting because it's the only case, but also in terms of comparison to vasculitis, I've never seen a vasculitis with this diffuse an enhancement. In addition, generally there'll be more wall thickening associated with these enhancing lesions in vasculitis, and also the non-stenotic portions and the stenotic portions are all diffusely enhancing. So one interesting thing, and we'll talk about it in a little bit, is in the setting of subarachnoid hemorrhage, a lot of times there's enhancement. So could this case have correlated with a subarachnoid hemorrhage relating to the RCVS that was present or that had evolved over time and we weren't seeing at this time point? So next, to go to small artery angiitis, I touched on this a little bit earlier. In terms of the ability of vessel wall, the limitations of catheter angiography and luminal imaging to detect this. And this was a study done a number of years ago where they were looking at small artery angiitis with, or angiitis in general of the CNS with MR. And they found 6 patients with angiographically negative primary angiitis of the CNS. And in 5 of those 6 patients, they showed enhancement and enlargement along the perivascular spaces, which improved markedly after or resolved after steroid therapy. And so here's a case that we had where you can see the MRA is completely normal, but you can see these curvilinear areas of enhancement within the brainstem. And we also saw this subcortically in multiple areas, this curvilinear enhancement here. And this patient had biopsy and had a diagnosis of granulomatous angiitis of the CNS. So we're not saying vessel wall imaging has better resolution than catheter angiography, but with catheter angiography, it's tough to see what's not there, especially when what you're looking for is lenticulostriate branches. You know, if there are a couple of lenticulostriate branches that are picked off, that's going to be something that's very difficult to see. With vessel wall imaging, you're not looking for those arteries that are lost. You're looking for the perivascular inflammation. In the setting of active inflammatory disease, that inflammation is going to spill out of the arterial wall. It's going to spill into the periarterial space, the perivascular space. It's also going to spill into the surrounding parenchyma. And so in that setting, the scenario I like to use, or the metaphor I like to use, is we're not looking for the atom bomb. We're looking for the mushroom cloud that results from the atom bomb with vessel wall imaging. With catheter angiography, you're just trying to find that little atom bomb from a satellite picture. Here's another study that was done that doesn't necessarily agree with what I just said, but they looked at 31 patients with primary angiitis of the CNS with either histologic or clinical criteria. In this paper, they really didn't describe their imaging method. They just said they did scans over the span of 6 years, which kind of, you know, I'd be very surprised if all of these were vessel wall imaging. I'd assume most of these were probably just MR studies done in these patients, but also at different field strengths, 1.5 and 3T. And with those 31 patients, a majority of them had biopsies, some had no biopsy, and most of them had MRA and catheter angiography, both. And what they found was patients that had positive biopsies, they said generally had negative MRAs and DSAs. And patients with no biopsy or non-conclusive biopsies generally had positive MRA and positive catheter angiography. And their conclusion from this was, you know, if it's involving proximal arteries, you're going to see it on imaging, and the biopsy is probably going to be negative. If it's involving peripheral arteries or small arteries, the biopsy is probably going to be positive because you're going to do a peripheral biopsy, and the imaging is probably going to be negative, which is, you know, it's another study evaluating that. I think there were some questions for their study, as we mentioned earlier, with steroid therapy, small artery vasculitis is more likely to melt away and disappear on imaging, mainly because what you're looking for is the perivascular inflammation, not the wall inflammation, and that's going to go away a lot quicker with therapy. So these patients, if they had been on steroids empirically before that imaging, that really limits the ability to detect disease. What were their protocols? They don't mention them. It wasn't clear whether these biopsies were targeted or random, and also the experience of these people in terms of looking for vessel wall imaging. There is a steep learning curve in terms of this evaluation, especially if you're not used to seeing small artery vasculitis and perivascular enhancement, and being aware of that and not just looking at the large arteries. Those are some important points to take home. I don't know the answer to these questions, but just some questions in regards to the study that they did. So what we did is we did a couple studies looking at added value of vessel wall imaging to support its value in the setting of disease differentiation. We looked at consecutive patients with luminal stenosis and clinically defined vasculopathies. We had a panel of 3 stroke neurologists evaluate each case and look at clinical data as well as luminal imaging data to determine what they thought the patient had. From there, 2 radiology raters evaluated the disease on luminal imaging and looked at a per lesion and a per patient assessment to determine what they thought the patient had based on luminal imaging as well as certain imaging metrics. And then after a 6-week washout, they reevaluated the patients with luminal imaging plus vessel wall imaging. And we had a total of 54 cases with 201 lesions, and we found that there was a significant improvement in diagnostic accuracy when vessel wall imaging was added in all categories of disease and a combined category. And generally, those accuracies went from 8% to 60% in the luminal imaging category alone to 80s and 90% when vessel wall imaging was included. So a significant and dramatic change in terms of accuracy. In addition, we looked at the inter-rater agreement of diagnosis, and there's a dramatic increase in terms of that agreement between raters, where it went from 35% to 82% in terms of agreement of diagnosis. And in prior studies, we looked at the agreement on pattern of involvement, and there was only slight agreement with luminal imaging, with substantial agreement when vessel wall imaging was used. In addition, in terms of looking for pattern involvement, as we mentioned, atherosclerosis we usually think of as being eccentric. And we say that on luminal imaging, we say that on vessel wall imaging. If it's eccentric, you should probably think of atherosclerosis. We looked at the correlation between atherosclerotic pattern and the clinical diagnosis of eccentric pattern and the clinical diagnosis of atherosclerosis. We found that there was significant agreement for both luminal imaging and vessel wall imaging, but the relationship was much stronger with vessel wall imaging. And that was a significant difference in terms of kappa values. In addition, we generally say atherosclerosis involves proximal arteries, vasculitis and RCVS involve peripheral arteries, and we found that relationship didn't really stand up when you looked beyond the ICA. So MCA, M1, M2, M3, A1, you look at arteries beyond the ICA, and there really isn't much correlation in terms of pattern. We did the same study with Moyamoya vasculopathy, looking at Moyamoya disease, atherosclerotic Moyamoya syndrome, and inflammatory vasculopathic Moyamoya. And we found similar results to where when we included vessel wall imaging, and this study was similarly designed relative to the prior study, there was a significant improvement in most categories in terms of accuracy, going from 30% to 80 to 90%. The only category where it wasn't significant was the inflammatory vasculopathy category, and that was mainly because we had such few cases, but there was a dramatic difference in terms of that accuracy. And just to show you similarly with Moyamoya disease, we typically don't see wall thickening, and you can see on the T2 there's not much wall thickening involving that left carotid terminus and MCA that are occluded. And there's not much in terms of wall thickening and enhancement that we see on the T1 post. While with atherosclerosis, we see this mushroom cloud of enhancement, right, and eccentric wall thickening, both involving the carotid terminus and the ACA here. And then in the setting of vasculitis, everything is kind of enhancing. And similarly, we can see the T2 hyperintense band and that wall thickening involving atherosclerosis, nothing on Moyamoya disease, and iso-intense wall thickening on the inflammatory vasculopathy case. And I do want to mention in terms of collaterals, we talk about collaterals in the puff of smoke for Moyamoya disease. And sure, it really stands out in some of the intermediate stages of this modified Suzuki classification. But A, these collaterals are compensatory, and we see collaterals in atherosclerosis frequently, as we all know. And B, they don't exist in the early and late stages of Moyamoya disease. So they may not be present at all. And the literature generally agrees with us that generally there's not much wall thickening in Moyamoya disease. The walls appear smooth. There's not much enhancement. If it is present, it's mild. While atherosclerosis similarly shows that eccentric pattern with positive remodeling and enhancement. There was one study from Korea where they found that Moyamoya disease or probable Moyamoya disease, they had those two categories, showed concentric enhancement in most cases, both ipsilateral and contralateral to the symptomatic side, but there was never remodeling in their group. Atherosclerosis showed less enhancement overall. On the symptomatic side, more. On the contralateral side, less. Generally, it was eccentric, and there was always remodeling. And the question is, why do their results differ from most other groups? And a few questions is, could they be looking at a transient stage of inflammation? Could Moyamoya disease be a very heterogeneous disease with heterogeneity of pathophysiology that ends up at a common point of steno-occlusion of the carotid termini? Could it be kind of a genetic subgroup that they're looking at? As we know, there are a lot of there could potentially be genetic contributors in this disease as we think about RNF and R4810K components. Or could it be a vascular flow effect relating to their protocol? And I did want to show this example that we had of a case with some enhancement involving that MCA right here, without much wall thickening, and again, without much remodeling or signal abnormality on the T2 weighted image in a patient that did have Moyamoya disease. And I did want to also point out this paper that was published a while ago looking at the histology of a case series of Moyamoya disease patients where they did find that there was infiltration of T cells in a certain layer of the arterial wall, and they surmised from that there could be a transient inflammatory process associated with Moyamoya disease. So this kind of adds a little more complication to the Moyamoya discussion. Another study we did was looking at patients who had ruptured aneurysms and subarachnoid hemorrhage. We looked at 31 consecutive patients who were coiled post-rupture with vessel wall imaging. And we imaged them, obviously once they were stable, but as close as we could to when they were treated. We had 9 unruptured and 22 ruptured aneurysms, and there was a significant association between ruptured aneurysm and subarachnoid hemorrhage and the presence of enhancement with an odds ratio of 6.5. As we mentioned in that RCVS case, subarachnoid hemorrhage can lead to enhancement of the arteries secondary to inflammation. When we looked at an analysis on a per segment basis, we found significant association between branch enhancement and development of angiographic vasospasm when controlling for hemorrhagic grade. With an odds ratio of 3.9. So that was a significant result. And just in looking at a few cases, here's a case of a patient with a right pica aneurysm which ruptured and diffuse basilar subarachnoid hemorrhage. On the initial catheter angiogram, you can see there's no arterial stenosis here. And on the vessel wall imaging, those little arrowheads point to a segment that shows enhancement involving the right proximal M1 MCA, and on the subsequent catheter angiogram done, I believe 5 or 6 days later, showed multifocal vasospasm present in the setting of that subarachnoid hemorrhage. In addition, we found that there was a significant association between assisted coiling or diversion and enhancement in the segment that was selected by the balloon or the stent, and you can see that example right here, and the odds ratio for that was 7.4. In addition, we had a couple cases where the vessel wall imaging did a better job than the modified Fisher grade in terms of prediction of vasospasm. This was a case with a prominent ACOM aneurysm right here that had ruptured. You can see a little bit of hemorrhage here in the anterior sulcus. It was a Fisher grade 1. And on the vessel wall imaging, you can see clearly enhancement involving that supraclinoid ICA there. And this patient subsequently developed vasospasm in that same segment that was enhancing. So it could potentially contribute to prediction of vasospasm in these sort of settings. And just kind of pivoting to vessel wall imaging of aneurysms, we've started to do work in aneurysms, and we found, as others have found, that the degree of enhancement is significantly associated with vulnerability of aneurysms, specifically based on clinical scores of vulnerability. And we also found that there was a trend towards significance of the degree of wall thinning, focal wall thinning within aneurysms, and its association with higher phases scores. And here's an example of an aneurysm that shows circumferential wall enhancement that is fairly large here. And here's an example of wall thinning, where you can see there's a little area of wall thinning posteriorly here that the raters detected. Right there and right there. And in terms of determining which aneurysm was vulnerable, vessel wall imaging can also help in that. This is a patient with diffuse basilar subarachnoid hemorrhage. There were 2 aneurysms. There was a left supraclinoid ICA aneurysm and a basilar tip aneurysm. Oh, whoops. And the question is, did this guy rupture or did this guy rupture? And the pattern of hemorrhage you saw was fairly diffuse and tough to really tell. When you look at the vessel wall imaging, one aneurysm enhanced and the other one didn't. And so in that setting, you can say the one that enhanced is probably the one that ruptured, and that was the one that was treated first. And this patient ended up having good outcomes. And here's another case. Patient had some subarachnoid hemorrhage there, and on CTA, there was this little guy, but it looks like there's an infundibulum coming off its tip. You see those little wispy branches coming off of it? And so that was the neurosurgeon's initial assessment, is this is just an infundibulum. That's not the source of hemorrhage. They said, let's do a vessel wall imaging study to look for dissection. And on the vessel wall imaging study, you can see that there's enhancement at that cap right there. And my statement to them is, I've never seen an infundibulum that enhances. I don't know why an infundibulum would enhance. I would assume this is an aneurysm. They went on to catheter angiography. You can clearly see that this is not an infundibulum, it's an aneurysm. They went on to treat it with successful results. Another example, left PCOM aneurysm. You can see thinning along that dome, or along that little nipple of the aneurysm where these arrows are pointing. In addition, vessel wall imaging can help in terms of detection of atherosclerotic plaque associated with aneurysms. And here's an example with an eccentric lesion along the parent artery there that's enhancing. You can see that discoloration was vasa vasorum involving the parent artery there above the aneurysm. All right, guys, so I think we're running out of time. Just quickly, one other thing we've been doing is segmentation of intracranial arteries, where we can segment arteries. We can create a lot of quantitative features of these arteries, and we've done a few studies in regards to assessment of these, and we found that it is a reproducible technique. And our hope is to start moving. We've started to move in the direction of using this for further evaluation of vascular disease. So in summary, vessel wall imaging can help detect arterial occlusions in acute stroke, has a potential in vasculopathy differentiation characterization in the setting of stroke, and with this, appropriate therapy can help prevent future strokes in these diseases. But continued investigation really is necessary to better determine its value and role, and that our understanding of these diseases continues to evolve. Thank you, guys.
Can we open the microphone? Oh, here we go. 3T versus 7T. Do you have any experience with that?
So we don't have a 7T. I think, I don't know if you guys have a 7T or not.
No.
I think there's a trade-off with 7T. There's the potential to get magnificent resolution and visualize things you wouldn't with 3T. But I imagine due to the field strength, you're going to get a lot of artifacts. And I think in a lot of studies, it's probably going to denigrate the quality of the study as opposed to improve the quality, secondary to the field strength. And so I would probably go with 3T personally. I think 3T is a good combination of high resolution, high SNR, and limitation of those difficulties and those growing pains that are going to happen as protocols are developed on 7T and really maximized.
And to Dr. Shammer, where are we with our protocols, what we're doing that is similar to Mahmoud at Baptist?
Our protocol is basically he's done most of his work with Siemens and Philips, but ours is basically the GE equivalent of that. So we can do pretty much everything that he has. And we've actually had some very recent upgrades to our 3T scanner in the basement. So our image quality has significantly improved in the last 3 months. So we can do pretty much what he is doing, though we haven't used it for all the applications that he has, but I think we have the ability. I do have one quick question. That was very interesting about the aneurysm rupture and predictor of vasospasm. Have they done prophylactic Rapamil use in prevention of vasospasm when you see imaging findings that suggest inflammation of the artery after a rupture?
So far, you mean based on the vessel wall imaging? So we haven't done it for the treatment of vasospasm. One thing we have been doing is in the setting of patients who have gotten a pipeline stent and have enhancement of the aneurysm. In that setting, the delayed rupture concern that develops in that setting, they will be more aggressive in terms of treatment with those cases. But we haven't gotten to the point to where we are doing prophylactic treatment based on the enhancement of the vessel walls. Hopefully with the next study we're going to publish in that space, hopefully that'll get us to that point.
Yeah. Just one for collaboration. You said you had a paucity of posterior circulation atro. We don't have that problem in Jacksonville. We have a excess of. So I think with Derek and the team, we can provide you probably 30 in a month because we see that it's ridiculous the amount of posterior circulation atro that we see here.
Yeah,
it's sad, but it's true.
That'd be great. We'd love to work with you guys.
I've noticed in the elderly population, particularly in the vertebrobasilar system, enhancement of the vasa vasorum. And that kind of is I just kind of read through it. If I only see enhancement in circumferential and long segments in the basilar inverts, kind of just assume that's what it is, especially if they're over the 70 or so. How do you deal with that?
Yeah, so vasa vasorum typically only enters the intradural space by a couple millimeters, 2 to 3 millimeters. In healthy young people, generally there's no vasa vasorum in growth. But as you grow older, stuff happens to your arteries. Atherosclerosis develops, hypertension, all those sorts of things result in thickening of the wall, and you get recruitment of vasa vasorum growing from the extradural into the intradural and along the course of the arteries. And as that happens, you will, as you mentioned, you will get enhancement along the arteries. That's part of the criteria that we developed. And what we said was that if there's smooth, homogeneous enhancement of the artery wall without outward remodeling and without stenosis, in that scenario, we consider it most likely to be vasa vasorum. Because vasa vasorum ingrowth should not result in stenosis. It shouldn't have areas of non-enhancement and heterogeneous enhancement, because that growth should be fairly consistent. So that's the way we characterize vasa vasorum. And I think it's a valuable thing to keep in mind and consider, because I've seen people call that vasculitis, which obviously it isn't, and you don't want to go down that pathway with those patients. Yeah.
Thank you.
Thank you.
Thank you, Mahmoud. It is. With all the respect to Kevin and Mahmoud, I think it is my distinct honor to introduce Dr. Virmani. I'm a fan of her work since I was a young child in Buffalo, New York, when I met Dr. Virmani through Nick Hopkins. Again, she's the walking Bible of atherosclerotic disease. And if we could spend the whole day here, well, I'm sure we would come out of the room much more enlightened than we are about this disease. But Dr. Virmani kindly accept to be here, and I'm sure we're all going to learn a lot from her. Thank you, Renu.
Thank you for inviting me, and it's a pleasure to be here. And I must say I'm learning at the same time. So it's definitely a great pleasure to be here because nothing like learning. So I'm going to talk a little bit on atherosclerosis, not purely. So my talk is going to be divided into atherosclerosis. I'm going to give you on coronary because that's where I've done most of the work. Talk a little bit of periphery, though you don't always see it, but there are some things which are different and unique. So I thought it would be good to put it in so that you get a better idea of what's going on in atherosclerosis throughout the body. And carotid, and I'll also speak on the intracerebral arteries. Then I'm going to talk about the types of thrombi which are seen in stroke and a little bit on cardioembolic thrombi and where they come from, and aortic arch atherosclerosis a little bit at the same time at the end, if I have time. So to begin with atherosclerosis, I think all of you know this and I don't have to get into it, but by far atherosclerosis starts in the aorta, then you get it in the coronary, followed by the carotid, and then peripheral artery disease. And of course, there's also intracerebral disease, which usually is amongst the last to get atherosclerosis. Now, when you look at how has it been classified, atherosclerosis, this was the study which was published in 93, 94 by Starry with the HA classification saying that it is divided into 6 different types. And I, myself being a poor pathologist, I don't like types. I like description rather than saying just type. So I'd like to call this type 1 as adaptive intimal thickening. Type 2 is what we used to know as fatty streak lesions, that is macrophage infiltration. Type 3 is adaptive intimal thickening. We start getting lipid pools. Type 4 is when a necrotic core forms, and it's called a fibroatheroma. Now, type 5, I don't know how they separate. The only way they separate is that the fibrous cap is thick. And then comes the area of type 6, which is when thrombus or hemorrhage occurs, and that was their classification. So I didn't like it. So when I looked at coronary arteries, and I started in the 80s, actually, I worked for Bill Roberts, and then my interest grew in that, and I said, I'm going to learn on atherosclerosis. And so we collected something like 2,500 cases of sudden coronary death. And so I said, this is how to learn. So these are people who had never manifested coronary disease before. They had never had symptoms. Their first symptom was sudden death. So all the work that you're going to see is based on those cases, majority of the work. So when you look at thrombosis, what are the causes of thrombosis? So it wasn't just plaque rupture, which leads to coronary thrombosis. There was plaque erosion, and there was calcified nodule. And I'll come back to those. These are the 3 types showing you here, showing you plaque rupture, plaque erosion, calcified nodule. So we all know the natural history of atherosclerosis. I think we've learned it in medical school, and all of us know that it makes a difference. What are the systemic factors? What are the local factors? And thrombosis. So I'm going to concentrate, where does atherosclerosis occur? It essentially occurs near branch points. It is not a random disease. When people think about it, they think about random. If you were to look at an autopsy, you will see the first things, where does plaque form? They always form near branch points. So when it progresses, for example, people say in diabetes, it's a diffuse disease. It's not really a diffuse disease. It's diffuse disease because thrombosis forms and the thrombus propagates, and that heals and gives rise to a diffuse process. So I think we must learn to label what is atherosclerosis, not just thickening of an artery, being atherosclerotic. So those are some of the things that as you can see here in the carotid, you can see very well that it occurs at branch points. Here again, left main, that's the left anterior descending left circumflex. Look where the plaques form. At the carina, it is actually spared. High shear regions don't get atherosclerosis, low shear regions get atherosclerosis, and that's determined by the branching. This is to show the progression of atherosclerosis. This is a paper we just recently published, again, showing what we think these are non-atherosclerotic lesions. That is, you have intimal thickening. This is just from blood flow, you will get intimal thickening. Intimal xanthoma, that is the fatty streak, this is a lesion well described in PDA to regress. Because what they did, they looked at 15-year-olds and they looked at every 5 years autopsies were done. And they showed that at 15 you can see lesions, but you may not see them at 20 because they regress. So therefore showing that these lesions can regress. But what are the lesions which are progressive? These are the lesions which are progressive. That is pathologic intimal thickening. They can occur with and without macrophages. You can have fibroatheroma. We call it into two types. There's early, late fibroatheroma when it's a real necrotic core. Early fibroatheroma is one when macrophages infiltrate into that lipid pool. Then, of course, there's a stage of thin cap fibroatheroma, which used to be known as vulnerable plaque, till we defined it, that it has to have a thin cap, it has to be infiltrated by macrophages, and it must have an underlying necrotic core. That is what constitutes a thin cap fibroatheroma or a vulnerable plaque. So here again, showing you the various causes. As you can see here, this is rupture. You can see the large necrotic core, and you can see where rupture has taken place, and there's an overlying thrombus. You can see the cholesterol clefts. Plaque erosion is a lesion we described many years ago now, I think close to 20 years ago. This is a lesion which shows underlying either pathologic intimal thickening, as shown here, or a fibroatheroma, that is underlying fibroatheroma. But there is no communication of that fibrous cap with the underlying necrotic core or the lipid pool. So there is no discontinuation of the fibrous cap. The cap is thick, and there is an overlying thrombus. We believe, at least in majority of the cases, this occurs from vasospasm. Then there's calcified nodule in highly calcified arteries. What happens, the calcium sheets break up and they protrude into the lumen. They can also protrude into the adventitia. These are very rare intracerebrally, but they are seen everywhere else. That is coronary, carotid, as well as in periphery, and much more so in the periphery than anywhere else. So, and then, of course, there is what is known as 10% of cases, there's a plaque fissure. That is, if you look underneath, there is an eccentric sort of communication of the necrotic core with the lumen, and this occurs without a real true thrombus. There is minor thrombus formation. It almost never causes a luminal occlusive thrombus. So those are the basic causes of progression and of thrombosis that occurs. Then we also describe the other factors that can give rise to. We see plaque hemorrhage. We see this heel plaque ruptures. They can be single underlying necrotic core when it's a single heel plaque rupture, or that means there can be silent plaque ruptures and they heal and give rise to a heel plaque rupture. There can be multiple plaque ruptures and that gives rise to the narrowing. We think luminal narrowing to something like beyond 40, 50% only occurs through asymptomatic ruptures or asymptomatic thrombi that can occur. Beyond that, suddenly the lumen doesn't narrow. Any other way is plaque hemorrhage. Plaque hemorrhage can also cause a luminal narrowing, sudden luminal narrowing. And now there are some work which has been done by OCT showing how these plaques progress. So it's interesting how people have come around to thinking like we have done. Then there is healed lesions, which are fibroatheromas, that is fibrous plaques, fibrocalcific plaques that don't have much of a necrotic core, but have a large calcium component as well as fibrous tissue. Then nodular calcification, when the nodules of calcium that are broken up are within the plaque itself. And then, of course, there's that true fibrous plaque, which I don't call atherosclerosis. That's from when a thrombus has healed. This is what it's going to give rise to, a propagated thrombus. So this was the classification. When we came up with our classification, Starry wrote an editorial and said, this is his classification. He says intimal highly susceptible sites, intimal moderately susceptible sites. These are the regression lesions and progressive lesions. And then, of course, fatty streak and fibroatheroma, and then calling it isolated lipid pool, fibroatheroma. He goes on, and to me, it is still confusing. The only thing that he has come up with is plaque rupture, still doesn't explain what is plaque erosion, why does it occur, and calcified nodules. He calls them calcified lesions and fibrous lesions. So these are his classification. So I just wanted to show some of the cases, that what they look like. This is a case, you can see a plaque rupture, you can see the thin fibrous cap, you can see the underlying necrotic core, and you see the overlying thrombus. This is the same matched section. Necrotic core, overlying thrombus, thin fibrous cap, which is disrupted, infiltrated by macrophages. You can get T cells, and you can have very few smooth muscle cells. It's type 1 collagen rich. And this thin cap we measured many years ago and showed that the mean thickness of that cap is 21 micron. And if you look at the 95 confidence interval, so thin cap fibroatheromas would be 65 microns in the coronary. Coronary arteries is very different in the carotid. Carotid, we've seen that it's as high as 110 microns. So these are the features of ruptured plaques. As you can see, it has to have a thrombus. It has to have a large necrotic core, at least 30% fibrous cap, which is covering less than 65 micron, as I said, many macrophage infiltration, few smooth muscle cells. It is expansile remodeling has occurred in such a vessel, and new vascularization occurs. That is, vasa vasorum come into the plaque and therefore are vascularized. Most of us think that plaque hemorrhage occurs from those vasa vasorum. There can be periadventitial and inflammation, and we've sort of seen it more progressive. I haven't written the paper as yet, but it is far more progressive in plaques that rupture than anywhere else. We see that much more so, accompanied by inflammation. And there can be, of course, spotty calcification, and also intimal medial inflammation may be seen. So this is to show a plaque erosion. You can see that there is no communication between the underlying plaque. This one is a lipid pool. That is, it has proteoglycan and lipid at the same time. If we do a frozen section, and we can show at this area, there is lipid present in that. But there is still a matrix. What we call as necrotic core is there has to be no matrix. That is, proteoglycan or collagen cannot be present. So it is really just a pasty material. That's why the gruel, that's why the name fibroatheroma. And you can see in the lumen, there's a thrombus. This cap is intact, seems to have very recently formed, and you can see that gross thrombus quite clearly. So this is a typical example of what we see in plaque erosion, a typical history. Plaque is a 33-year-old woman complaining of chest pain for 2 weeks duration, was discharged from the emergency room with a diagnosis of anxiety, and she dies 2 weeks later, suddenly, while walking on the street. And you can see that her LAD is severely narrowed. It does have an overlying thrombus. And if you look at all this, likely this occurred in the past 2 weeks. This is smooth muscle cell rich. Look at the platelet deposition. Look at the fibrin deposition involving that whole region. We can't quite differentiate that well, but our immunostaining shows us very well, and there's still, so obviously she didn't have that severe a narrowing when it started, but it actually became severely narrowed by the time she died. So what we've done is looked at percent narrowing in plaque rupture and plaque erosion. We can show you very nicely that ruptured plaques are more narrowed as compared to plaque erosions, them less narrowed, less severely narrowed. And you can see that if you divide it by tens, this is in plaque ruptures, 57% or less than 75% narrowed, 79% narrowed. Whereas here you can see in erosion, 82% are less than 79% narrowed. So it just tells you that these are early lesions. They occur in the young, and they are more common in women than men, especially in the young age. And I'll show as a summary. So this is plaque calcified nodule. You can see here below, you can see that there's a nodule formation. It is overlying with a thrombus. This is in the area of the left main. This is left circumflex next to it, which is heavily calcified artery. And you can see that the lumen is still intact. There's no overlying thrombus. Here, there's an overlying thrombus. So what do we think? How do these lesions form? We believe that plaque fissure can give rise to discontinent and enlarge a plaque slowly. Plaque rupture can rupture and cause a thrombus on the lumen, which is almost always platelet rich. The propagated thrombus is the red thrombus. The thrombus which occurs over the plaque rupture site is platelet rich and is a white thrombus. So when you look at healed plaque ruptures, recently formed healing lesions, smooth muscle cell rich, then it can be quiescent for a time, and you'll get calcification, fibrocalcific plaque. This is now sheets of calcium have formed, and that necrotic core has become calcified, or may not get calcified, but the rest of it is calcified. And then you see that with time, especially in regions where the artery is very tortuous, like the right coronary artery, the left anterior descending, you find that these nodules can form, and these nodules can protrude into the lumen eventually and give rise to the thrombus calcified nodule. We believe that's the mechanism of formation. So in summary here, I'm showing you the influence of age on coronary thrombosis in men and women and the various types of plaque. On the left is females, on the right is males. You can see less than 50 years, over 50 years. Majority of the lesions in women less than 50 years is plaque erosion, the pink. And as you see beyond the 50 years is predominantly plaque rupture in women. In men, the dominant lesion is plaque rupture, less than 50. Whether they are less than 50 or beyond 50, the dominant lesion is plaque rupture. But erosion does occur, and it is seen in men, and it is again seen in younger men, not so much in older men. And then again, showing that they are quite frequent in young men. If you look at otherwise just the healed plaque, that is no thrombi, they are much more so in women less than 50, and I don't understand why that is so. Perhaps the incidence of diabetes is much higher in that population. We have a large number of African Americans, and that may be the reason. And then you look at beyond the 50 years, it sort of decreases. But in men, the reverse occurs. That is beyond the 50 years, the no thrombi lesions increase, and so does organized thrombus form, that is chronic total occlusion, increases with age. So calcification in peripheral arteries, they're very similar. Calcification occurs in the same way in the coronaries. That is, we see as plaques progress, usually don't see in AIT, but we start seeing in pathologic intimal thickening in areas of lipid pool where smooth muscle cell loss occurs, microcalcification occurs, especially when macrophage infiltration occurs, they become slightly larger. We call them punctate. They become fragmented. You can get fragmented calcification finally, and then you can get sheet calcium and plaque rupture here in the peripheral arteries as well. This is progression. This is showing you the calcification, again, showing microcalcification, larger plaques, and then fragmented plaques, and finally sheet calcium. Sheet calcium breaks into multiple. The black areas show you that's calcium because we have not decalcified those sections specifically to look at what calcium truly looks like without decalcification. And then, of course, you can get nodular calcium, and even bone formation can be seen. So in medial calcification, it's classically seen in the lower limbs, and you can see here the same type of calcification can progress. It can be circumferential, it can get even nodular, and bone formation can occur same way. So this is a summary showing the intimal and medial calcification, how they are different. If you look at intimal calcification in the peripheral arteries, you can see these types. You can see no calcification, followed by microcalcification, followed by fragmented calcification in gray, and then sheet calcium in blue and nodular calcium in yellow. And you can see that in the medial calcification in this particular cases, we did not see nodular calcification in the media overall, but medial calcification is not common, is very common in the peripheral arteries. We've seen equal incidence above the knee and below the knee. Some people think it's more below the knee, but we didn't find a difference. And then just showing the extent of calcification, that is fragmented, sheet, nodular, whether it's medial or intimal calcification. And then looking at greater than 25% circumferential calcification, you can see intimal is much greater as compared to medial and what is common. So what about carotid? It progresses the same way as anywhere else. We see the same thing, pathologic intimal thickening, early fibroatheroma with plaque hemorrhage. Then we see thin cap fibroatheroma there, and we see here an ulcerated lesion. What is unique in carotid is you see ulcerated lesions. And why do we see ulcerated lesions? They all occur from plaque rupture, but why do we see ulcerated lesions? Probably because of high shear force, and therefore you get emboli, and that's how stroke occurs. So therefore, it is very uncommon to see a large thrombus in the carotid artery, especially in a patient who comes with a stroke. It's already embolized, and we see usually very small thrombus as shown right here. You can see a large plaque hemorrhage. You can see calcified nodule. You can see multiple heel plaque ruptures, plaque hemorrhage, and you can see chronic total occlusion, heel plaque rupture, and chronic total occlusion. Chronic total occlusion is very common in coronary, not that common in the carotid. We see as much as 20 to 30% of patients who are dying suddenly for the first time will have chronic total occlusion. They have had no symptoms of it. Whereas in the carotid is very unusual, it's about 10% or so, whereas in the coronary is 30%. Peripheral artery below the knee, extremely common. Over 50% will show you chronic total occlusion. In the peripheral artery, we believe it is more embolic phenomenon because we've seen ruptures above the knee and not, so there's very little atherosclerosis below the knee, but there's chronic total occlusion. So this is just types. I'm going to skip some of this because I think you've seen more of this than was given a talk earlier. This is just to show you that there are a large number of cases that have been collected and they are equally divided. Here we've tried to look for what's the difference in major stroke, AIT, and asymptomatic lesions. So I just wanted to show a little bit of that and saying that thrombi are more common in the case of stroke than TIA, than asymptomatic. Asymptomatic, the least common. And if you look at erosion, very unusual in the carotid artery. And I think that has to do with, it's a large artery, doesn't go vasospasm, whereas the other does. And then you have calcified nodule. Then fibrocalcific plaque, again, is much more common in the asymptomatic. That's why I actually question whether these plaques should be removed or not removed. That is, those that don't have a necrotic core, highly fibrotic plaques. This is just to, again, show you ulcerated lesion, plaque rupture from stroke patients. healed plaque rupture site and healed rupture site in those who are stable, asymptomatic cases. Now, this is just to, again, show you similar cases, just like coronary, we see similarly macrophage infiltration, large necrotic core. The lesions are very similar to carotid. That is, one thing that is different is they are very rich in macrophages. Richer carotid lesions are richer than we see in coronary. Hemorrhage, again, is very common in the carotid, not as common in the coronary, or less common in the coronary as compared to carotid. And of course, you get plaque ruptures similarly, and that's the most common cause of stroke. So atherosclerosis in the intracranial arteries, I just want to show you what is normal artery, basilar artery versus a normal coronary artery. You can see the IEL is extremely thick in the intracranial arteries. That is, internal elastic lamina is almost twice the thickness, and if not more, than what we see in the coronary artery. This is the internal elastic lamina. So you can see that there are no vasovasorum here. You can see vasovasorum in the adventitial vasovasorum in the coronary. So this is supplied by the cerebrospinal fluid, whereas here we are dependent on the vasovasorum for oxygenation. So just to show you some lesions, this is thin cap fibroatheroma in the basilar artery. This is a plaque rupture with overlying thrombus. It certainly does occur, and these lesions can have lesions within and these I got arteries from asymptomatic patients. These were just collected basilar arteries. Our intracranial circle of Willis was collected, and I just sectioned 20 of them, and that's how I got these. Again, showing extreme thin cap fibroatheroma with, you can see large number of macrophages. And in this case, you see nice vasovasorum present in the adventitia and within the plaque itself. As said before, vasovasorum are not really present in arteries which are intracranial, whereas they are definitely present in the extracranial. And they, as plaques develop, you start seeing them coming in. So just to, what are the thrombi which are being aspirated? So this is a study which came out in Stroke in 2016. Basically what they did was they divided their plaques into the thrombi that they aspirated into red cell rich or platelet and fibrin rich. And this is what they found, that if you look at successful versus unsuccessful reperfusion, that is successful and unsuccessful reperfusion, what I want you to concentrate on is atheromatous gruel. If it is present in the aspirate, they are more likely to be unsuccessful. And if you look at those that are successful, they're much more likely to have red cell thrombi versus those that are unsuccessful. So the ones which are more unsuccessful are more organized. That is, they have more platelet fibrin-rich thrombi. So that's what I was trying to show in this particular study. This is just to show the types, platelet-rich and red cell-rich thrombus. Aspirate. This is another study. What they did was they looked at erythrocyte-rich and again fibrin cell-rich, and they looked at thrombus density that they could see in Hounsfield unit, and they show that overall erythrocyte-rich is more dense as compared to fibrin-rich, the Hounsfield unit density. What they showed most important was the number of maneuvers that they had to perform to get the thrombus out was much greater with the fibrin-rich thrombus as compared to red cell-rich, which is not surprising. Fibrin gives rigidity, and fibrin also is a mechanism how thrombi organize. So it could also mean where are they coming from. If they are really fibrin-rich, they could be more cardioembolic rather than just in situ. But you can, as I said to you, at sites of rupture, they are platelet-rich thrombi. So this is again just to show how they analyze this. They looked at leukocytes and others. And differences in procedures, the average recanalization time was much less in those that were erythrocyte-rich as compared to those that were fibrin-rich. And again, the number of maneuvers was much less. So this is to show the correlation erythrocyte and duration time. You can see that the duration decreases as the duration increases as the number of erythrocytes decrease. Whereas if you have fibrin-rich, the duration increases as the fibrin-rich increase. So leukocytes have no influence, and the difference in mean percent thrombus composition or by TOS class, really we didn't see that much differences. So if you look at cardioembolic stroke, 15 to 30% form from cardioembolic stroke. These are, more than I do in a way. They can come from the left atrium, the left ventricular thrombus. They can be cardiac myxomas and vascular changes and complex aortic. And I will show you some of these, not all of them, obviously. Most important is the left atrial appendage. Here, atrial fibrillation and ischemic stroke. You can see as age advances, so does atrial fibrillation increase and stroke rates increase. And you can see increasing atrial fibrillation with age. These are the various types of atrial appendages. They've divided them into single lobe, multiple lobe, as shown here, and they've named them 4 different types of atrial appendage: chicken wing, windsock, cactus, and cauliflower. What's important is that if you look at this, cauliflower has the least cardioembolic, that is 4%, whereas if you combine the 3, which are only, the 3 together form 50% of the atrial appendage, 50% are chicken wing, and the incidence in chicken wing of embolic phenomenon is 4, whereas all 3 combined, that is windsock, cactus, and cauliflower, it's 12%. What about the lobes? The incidence of lobes also without thrombus, they are much more 2-lobe, but less and less 3-lobe. But if you look at those with thrombus, they are more 3-lobed than 4-lobed, and they tend to be much more embolic in cause. Now, it really makes a difference whether you have non-rheumatic atrial fibrillation or you have rheumatic atrial fibrillation. Where does that thrombus lie? The thrombus lies in the left atrial appendage in the non-rheumatic. Very few are in the left atrium, it's our cavity itself. Whereas in the valvular case, it's almost 50-50. That is left atrial appendage, about 57%, and 43% in the left atrial cavity. The Japanese did a very nice study, and what they did, they removed the left atrium, and they looked at the thrombus in the incidence, looking at whether they had, what type of thrombi were seen in the atrial appendage in the patients who were getting emboli and who did not have emboli. So what they showed was if you have a mural thrombus, this is a mural thrombus in the appendage, mural thrombi tend not to embolize. If it's a polypoid thrombus that is projecting into the lumen, logically it makes sense and they tend to embolize. So that was the main thing that they found. And of course, there are some other differences. The larger the atrium, the more likely you will get polypoid. This is just, the blood factors also make a difference. If there's erosion, there's no erosion of the surface, loss of endothelium, and stasis all make a difference in forming the thrombus. And then last of all, when you see in the left ventricle, when do you see what's the best way to identify? The best way to identify is contrast-enhanced cardiac magnetic resonance rather than just an ultrasound. And that in those people who have much more LV thrombus, which present is those had a lower ejection fraction, which makes sense that they had a lower ejection fraction as compared to those who did not, they had better ejection fraction. So cardiac embolic stroke, main source is the left atrium, especially in patients with atrial fibrillation. As stroke rates increase, the increase in aging population, so does atrial fibrillation increase. And contrast-enhanced cardiac magnetic resonance is a better method of detecting LV thrombus in patients with left ventricular ejection fraction less than 50% or AMI. So just a few words on aortic atherosclerosis. Approximately 45% of individuals aged greater than 45% harbor atherosclerotic plaques in the aorta. And this has been associated with stroke. All of you know that. Larger, ulcerated, non-calcified or mobile atheromas are the ones which are going to give rise to stroke. And this occurs in about 8% of the population. I think it's a little overestimated. This was from the French registry. They came up with 12%, but I think overall it's not that high. But if you look at atherosclerosis in the aorta, you can see this is a normal aorta. This is what is known as fatty streak surface. This is known as fibroatheroma. Look at the ulcerated lesions. And this is a thrombus which is sitting, which would embolize, more likely to embolize, especially when it's in the arch. Again, showing the same thing. The Japanese have classified it in a different way into 8 different types. And again, showing here in the abdominal aorta, you can see, but that's not what influences stroke. It's the arch thrombi that make the difference. So this is just the histology, showing you the histology of that different plaques, similar to what I showed you in the coronary, carotid, peripheral artery, all of them. This is my last slide, basically showing that where are the sites of attachments of 13 thrombi in 10 patients. Basically, it is all in the arch. In the descending aorta, there were no descending aorta atherosclerotic plaques that had embolized. So it just makes sense, because unless there's retrograde flow, you're not going to get, and it's not likely to be. And here showing the large thrombi by CT, you can see very nicely. And this is an example of showing excessive atherosclerosis in the arch of the patient with atherosclerosis. So thank you so much for this opportunity.
Thank you very much for that interesting talk. It was great. Quick question. So we do see a lot of intracranial athero disease here. Basically 2 questions. Number 1, any thought as to why there's higher rate of intracranial atherosclerotic disease in this population here? And number 2, in particular with diabetes, there has been more report of disease involving the supraclinoid ICA. And too
many questions.
Right. So the first question is, why do you think that we have high risk of intracranial disease in this population here? And the second question is regarding diabetes and supraclinoid carotid location for...
Diabetes, as you know, has been associated with higher incidence of atherosclerosis, poor outcome with PCIs, everything. The reason we looked at plaques, our plaques, the coronary plaques, people have done the carotid same way. They're showing that they have larger, greater inflammation and larger necrotic cores. But on the other hand, what we showed in our case, which is contradictory, is if you looked at patients who were diabetic and they died with the diabetes, we did not show a higher incidence of plaque rupture. What we showed was more diffuse disease, heel plaque ruptures. That is, they are silently rupturing their plaques, and therefore they build their plaques much more so than those who don't have diabetes. So it's sort of reverse in what you think. I think they get the disease, it is pro-inflammatory, they have silent ruptures, they go and narrow their vessels and have much more diffuse disease. That's when they will manifest their disease.
Thank you.
And the second question you had was?
The rate of intracranial disease is high in this area.
I think
it's a
partly
stroke belt that we call it.
Poor diet, probably. And I think together with it, diabetes being higher, I'm also sure hypertension is higher in these individuals. So they are more susceptible to. What I found in our coronary disease cases is we actually collected, we didn't know their risk factors. We collected kidneys, we collected all the blood, and we did all the analysis to find out whether they were diabetic or hypercholesterolemic. Guess how many of them had at least one risk factor? 99%. So I think risk factors do play a very important role. And the The only way to prevent this disease is to treat risk factors. Now we have wonderful statins. I don't think, people have called this atherosclerotic inflammatory disease. It's a secondary inflammatory disease. It's because the lipids enter in the wall, only then do your inflammatory cells come. So if you take away the lipid, no animal develops atherosclerosis. So cannot be just inflammation.
More questions, anybody? Crowd is pretty quiet. I think we need more coffee.
I think they don't know pathology. That's
So we're going to go for a 15-minute break, and we'll be back at sharp at 10:20, guys. Short break.
set it up this way. Figure that makes sense.
I got an HDMI on there. Yeah, I got an adapter.
Don't have a USB-C.
No problem.
And are you doing? You're doing this one
And then I'm doing one
the
couple later.
the debate.
The debate.
Is there any slides with that one?
There are. Yes.
And they're on your machine?
Yes.
Excellent. I don't believe anybody else in this section is using your computer for the podium. So if you want, I can set a PowerPoint up here for you.
Oh, that'd be good. Do you have a Mac PowerPoint?
I don't. If you have
I can go grab it. I'm full, so I should be in good shape.
Okay.
Should we check to see that it's projecting okay?
Yes, sir.
Are we?
We're good. Good to go.
Good?
Yes, sir.
Okay, great.
So, yeah, if you have a power cable you want me to plug in, we can do that.
Okay.
It's newer Mac, so I imagine.
Knock, knock. Hello, guys. When I said we restart at 10:20, the only guy that walked in the room was Professor Filler from Germany. I didn't understand exactly why. So we're going to switch gears from neuroradiology after a brilliant morning. We're going to go the rest of the day all the way till 9 p.m. No, I'm kidding, 7. On stroke and all kinds of varieties of aspects of stroke. So very exciting rest of the day. Our first speaker this morning needs no introduction. I think this is the 3rd time that we have the honor of having Greg Albers here, and it's pretty cool that whenever Dawn got published, we had in the same room Raul Nogueira and Greg Albers, and cheers to that. I think the work that they have done, Greg is specifically here, to prove that what we do works is phenomenal. So Greg needs no introduction, professor of neurology at Stanford. He's going to talk to us about the next trials in a stroke, his perspective. Thank you again, Greg. Always a pleasure having you here.
Thank you. This is a fantastic meeting, and it's a great pleasure to be here. And it couldn't be a more exciting time in the stroke world. Over the course of my career, virtually all the trials we have done in stroke have been negative, huge investment of time and effort for negative results. And the last few years, we finally got it right. We've got a plethora of positive trials that have come out recently, which means there's a huge excitement about continuing because there's still a long way to go. Even though we've had good results, we do not have 100% recovery in any of these trials. We're nowhere close. So I'm going to very briefly go over a few trials that are either on the horizon or just being launched to show you what I think the future will bring. And the way we got to the design of many of these trials were the learnings from DAWN and DIFFUSE-3. These were the late window trials that really, changed people's mind about how treatable this disease is and the fact that we don't have this ultra tight time window for the majority of patients. So I'm going to talk a little bit about some of those learnings, and it starts with the late window paradox. This was a huge surprise to many people. If we had asked you a couple years ago, where are you going to have a bigger treatment effect if you treat a patient early or you treat a patient late? I think we'd get 100% vote for early, and that's not what happened when you compare the Hermes results of the 5 early window thrombectomy trials with DAWN and DIFFUSE-3 that enrolled patients beyond 6 hours after last known well. And this was a statistically significant difference, a larger treatment effect with later treatment. So it's a paradox, and let's dig into that a little bit. If you take a look at the blue bars, that's the good outcome in the endovascular arm, and you can see that we didn't do better in terms of good outcome in the endovascular arm in the late window trials. We did about the same overall, but the prognosis in the medical arm was terrible. Patients who come in, even though they have salvageable tissue in a late window, they get randomized to the no thrombectomy arm with an MCA or an ICA occlusion, and you're looking at about 15% good outcome rate. So that's part of the reason for the paradox is there's this terrible, terrible outcome in the medical arm, which was not as bad in early window medical arm treated patients. So here's a slide that came out of the DIFFUSE-2 study. This was looking at how quickly does the typical MCA occlusion infarct develop. And the big surprise, and I think it took me 5 journals to get this published, the big surprise here was that half of the patients, the infarct on MRI is developing very, very slowly. In many patients, there's no DWI lesion for many hours, and then it takes off later. It's only about a quarter, 20 to 25% of patients who have this very rapid development of irreversible injury, much different than what we were taught in medical school. So when you overlay the clinical trials onto this graph, you can get a feel for why DAWN and DIFFUSE-3 did so well. They're taking the 50% who grow slowly. So by the time you get out to 6, 8, 10, 12 hours, anybody with a small core is in that green band of a very slowly growing irreversible injury. Whereas in these early window trials, particularly the less selective like Mr. Clean or Thrace, you're taking everybody. So that means you're getting that 25% who's growing really fast. And by the time you open the vessel, you may have a substantial amount of injury that you might not have had at the time you imaged them when they first came into your ER. So that's part of the explanation. We're getting the slow growing patients, so time is not as critical. Every minute doesn't matter in these green zone patients, where every second matters in the red zone patients. But let's take a deeper dive. And this slide is a little bit misleading, because if you look at the Hermes results from these 5 New England Journal trials within the 6-hour window, really, it was a very heterogeneous result. If you look at Mr. Clean, which was, take everybody who doesn't have a hemorrhage on their CT, so it's a plain CT selection study, you can see the good outcome rates in endovascular were 33. When you look at an aspect selection trial like Revascat, it's up to 44. And when you look at a CT perfusion selection trial that's looking for patients with salvageable tissue, it's 71%. So, when you mix them together, you're losing that heterogeneity. So let's compare apples to apples. Within the 6-hour window trials, SWIFT Prime and Extend IA used very similar selection criteria to Diffuse 3 and DAWN. So if we compare SWIFT Prime and Extend IA, we can see that the penumbral volume, 100 ml, was the same as in Diffuse 3 and DAWN. The age, the NIH stroke scale, was the same as Diffuse 3 and DAWN. What's the difference? It's the late time window. And here you see the paradox, shifting a bit. So when you look at the good outcome rates in the endovascular arm of DAWN and Diffuse 3, they're around 50%. That's not as good as in those penumbral patients treated in Extend IA and SWIFT Prime. But there's a big difference again here in the medical arm. So what's different between the medical arm of SWIFT Prime, Extend IA, and Diffuse 3 and DAWN? How do those patients differ? Well, they differ by the thrombolytic, right? Because in Diffuse 3 and DAWN, these are patients who missed the thrombolytic window. And in SWIFT Prime and Extend IA, 100% of patients got TPA. So I suspect that the TPA is really playing a role and that it benefits both groups. And again, this is a controversial point, whether the TPA really makes a difference if you're doing a thrombectomy. I think it does. I think it would have benefited our Diffuse 3 and DAWN patients if they had a thrombolytic on board, and it clearly would have benefited the control group that did so poorly without a thrombolytic. So what's the next trial that I'm really excited about? It's timeless, and you guys here locally enrolled the first patient, so we're really excited about that. Yeah, well done. This is going to be a 100-site trial, and it's fantastic. We're looking for more patients here, as well as the other sites that are getting activated. This is looking at TNK, so there's reason to believe TNK is more effective than TPA for dissolving these large vessel occlusions. TNK versus placebo in the late window. So the selection is essentially the same as Diffuse 3. It's penumbral selection, but we add the M2 segment, and we also add the peripheral sites, the primary stroke center, the spoke sites, so they can get randomized TNK versus placebo there. And maybe by the time they get to the comprehensive center, that M2 is open and you don't have to do the thrombectomy. But most of the time, these patients will go to thrombectomy. And again, I believe the combination of a thrombolytic and a thrombectomy is what's going to lead to the best outcome. Okay, what's next on the horizon? Well, I think the question about who else benefits beyond these patients who came into these penumbral selection trials like Extend IA, SWIFT Prime, Diffuse 3, and DAWN. So this is a little diagram saying in green, these are the patients in the early window that we know had a huge benefit at Extend IA. There must be more patients that benefit. When we designed these rapid-based trials, the idea wasn't, I'm going to find every patient that can benefit. The idea was that this is a field that is in big trouble after the IMS-3 results and Mr. Clean, MR Rescue came out negative. So we needed to find patients who would benefit. So patients with a large penumbral area have a big benefit. But who else can benefit? Well, you could still have a big core, but you could still have a large mismatch. So I think that that is a horizon for the future. And then we have to think about who doesn't benefit. Because there is certainly good evidence that if you have a massive core or if you have no mismatch, in other words, your stroke is completed, we should be able to agree that a completed stroke is not going to benefit from reperfusion therapy. So we need to identify exactly who's in this red box and exactly who's in that green box so we can expand the treatment to more patients. That's early window. What about late window? This is the way I see things. Obviously, Diffuse 3 had more broad selection criteria. More patients got in than DANTE, but clearly there were patients who we excluded that could benefit. But there are a lot of patients in that late window who've completed their infarct. So that's why this red zone looks so large here. And those are patients that we don't want to treat. And that's how I see the world. A lot of people in the late window that can't benefit, but a substantial number who can. Some people see the world like this. They think virtually everybody can benefit from this therapy. It doesn't hurt anybody. Virtually everybody can have some benefit. They see a small red zone in the late window. I don't think that's true. And the evidence for that comes from virtually every trial that's looked at treating late patients without selecting. Here's the Mr. Clean results, just looking at good outcome in patients who are reperfused over time. And as you can see, as you extrapolate these very depressing sloping downward curves that you've seen over and over again, it suggests if you don't select patients, there's not going to be a lot of good outcomes as you get out to 12 or 16 hours. We saw the same in Revascat. This was an aspect selection-based trial. And if you look at the patients who came in with an aspects of 6 or 7, you can see that by the time you're reperfusing them at 10 hours, the good outcome rates are not looking so good. So that's why I think that red zone is quite large, and we still need to select to find the patients in the late window. Who's going to benefit? Again, I think we can push that core up beyond 70, which was the cutoff in Diffuse 3, maybe up to 150, maybe even more, but they need to have some salvageable tissue to go along with that big core. So large core trials, there are several that are launching, SELECT2, In Extremis, Tesla, and Tension. The one that I am most interested in is SELECT2 because it looks at aspects and penumbral imaging in all cases, and that way we can sort out at the end of the day how much did the penumbral imaging add to a simple aspects-based selection. I've also highlighted down there late window trials with non-contrast CT selection only. The big one going on now is Mr. Clean Late. It's looking at just non-con CT, but it's looking at collaterals based on CT angiography because they are concerned that if you've got terrible collaterals in the late time window, that's somebody who may not benefit. Okay, what else is next? Well, I think there's a tremendous enthusiasm about treating the stroke during the time the patient is trying to get to your comprehensive center. In other words, we're seeing a lot of patients everybody's doing thrombectomy. Now we have a 24-hour window, so everybody with an MCA or an ICA occlusion within 24 hours needs to potentially be getting to a thrombectomy center. But you don't want to send everybody because a lot of patients are in that red zone with a completed infarct. So how do you decide who's going to make it and still have salvageable tissue when they get to your comprehensive center? And at the ISC meeting a couple months back in Honolulu, there were a large number of presentations about perfusion imaging-based collaterals. We're very excited about this because they can predict how fast that ischemic core is growing. Are you in the green zone with a very slow-growing core, or are you in the yellow or red zone where that core is growing much more rapidly? So here's an example. The blue map are patients who have very good collaterals based on CT perfusion, very mild delays in the arrival of the contrast agent because of those good collaterals. The red map is a patient with terrible collaterals. They're taking a very long time, more than 10 seconds for that contrast to get into the ischemic area. And this can be done in an automated fashion. You can see it immediately after your CT perfusion is done. And it's based on what we call the HIR, which is what % of the perfusion lesion has a severe delay. And here, I'll just show you a couple of studies. This is from Diffuse 3, showing that the patients who have the favorable HIR, the good collaterals, have much slower growth at 24 hours. They only grew 35 ml at 24 hours versus 84 if you had poor collaterals. And probably even more exciting was this paper that we put out in October in Annals of Neurology. This is just looking at one of our referral sites, Community Hospital in Monterey. It's 3 hours away from Stanford. And they've been using the rapid imaging for several years. So we looked at how do we determine who is going to still have a small core after that 3-hour transport. And if you had the favorable collateral pattern, the HIR, that's less than 0.5, less than half of the perfusion lesion is red, 88% were stable during that 3-hour transfer. Whereas if you had the unfavorable, more than half of the perfusion lesion was red, 83% had significant growth. I mean, that's incredibly accurate prediction. We're doing an NIH grant in a much larger sample size to verify this. So why is this important? It's important because people are very excited again about neuroprotective agents. It's a huge graveyard of neuroprotective agents way back in the 90s. They'd all failed, but they may have failed because we were treating the wrong patients, right? If you're treating a patient who is not going to grow during a few hours, then the neuroprotective isn't necessary. But if you can use the collateral imaging to say, this is the patient who's going to grow during the transport, that's the one you want to test your neuroprotective agent in, because that's where you're going to have a big impact with a small sample size. And there are several trials gearing up with newer neuroprotective agents looking at, let's freeze the core during that critical transport time from the spoke to the hub. Okay, here's something we're also very excited about. We've done now about a dozen kids in the last year and a half with the same imaging strategy that we used in Diffuse 3. So here's an example, 10-year-old healthy girl. She's found at the bottom of a slide, unwitnessed fall. Everybody immediately assumes this is some type of head trauma. It takes a very long time for these kids before somebody realizes that they're having a stroke. They never get treated in the ultra early window because you don't diagnose a stroke quickly in a kid. But here, by the time she finally got her MRI scan, you can see it's pretty obvious she's having a stroke. What do we see on the maps here? The core looks the same. Right, we see the area of either very low cerebral blood flow or diffusion imaging shown here in pink. That's the same as in an adult. What's different is that these kids have great collaterals, and rather than using the green Tmax 6 threshold to identify penumbra, we've been using the 4-second threshold. So here you can see this is a patient who is not speaking. She's obviously got cortical signs, but you would not see a mismatch based on the green usual Tmax 6 that we use in adults. The Tmax 4 shows the perfusion abnormality. The patient is recanalized, reperfused, and winds up freezing the infarct core, no cortical involvement, and having an excellent outcome. So this is going to work for kids, and we should be offering this to kids. There's no reason this hugely beneficial therapy should not be going down to the younger folks. So we proposed to the NIH a study called PETITE, and hope to get many of your sites involved who have pediatric services where we can do the imaging and sort out what's the best way to identify penumbra in kids, because it's likely to be a little bit different than in adults. Okay, next question. How long can salvageable tissue persist? Right, the DAWN study went out to 24 hours, which a lot of people thought was crazy to go out that far. But is that really the limit? Can we go beyond 24 hours? So we did a study in the control group of Diffuse 3. Remember, half of the patients were randomized to the medical arm, meaning no thrombectomy. And we re-imaged these patients on average about 37 hours since they were last known well, right? So they came in, typically about 12 hours. That's when they got randomized. And 24 hours later, they got another picture. And the question was, how many patients would still have salvageable tissue at 37 hours? And if I'd asked this a few years ago, hands would go up for 0, right? But what would you say now? What percent of patients with an MCA or an ICA occlusion who had salvageable tissue, within 16 hours of stroke onset, still have salvageable tissue 24 hours later? Any ideas? 18%. Okay, so we're losing the penumbra over that 24 hours in the vast majority of patients. 80%, the penumbra is disappearing, but 18% of these patients at 37 hours. And when we were screening for Diffuse 3, it was about 50% of the patients who met the imaging criteria. So of those 50%, you still have about 20%, so that could be as many as 10% of all MCA and ICA occlusions could have this incredibly long treatment window. Their mismatch volume has decreased. It was about 100 mLs when they first got into diffuse 3. By 24 hours later, in these 18% who continued to have salvageable profiles, it was down to 50%. But they weren't done. Just because your collaterals were so good to keep you with a low core for 37 hours, they continued to grow and the patients did very poorly, suggesting that maybe we could have had a rescue strategy in diffuse 3. So here's an example of one of these patients. She's a wake-up stroke patient, 73-year-old woman. Here's her core on DWI, only 5 mLs. She's got a right MCA occlusion. But this MCA occlusion is not what you typically see. There's only 41 mLs of Tmax 6-second delayed perfusion abnormality. And look how patchy it is. It's a relatively small lesion. It's very patchy. Why is that? Great collaterals. She had terrific collaterals. But the collaterals don't last forever. So look at the green map. What happens to it over the next 24 hours? Okay, look at the growth. It grows from 41 to 77, and those patchy holes are being filled in as the collaterals are failing. But what happened to her diffusion lesion? It went from 5 to 27. So she grew, but there's still a 50 ml mismatch. There's still potentially 50 mLs of salvageable tissue. So how big is her stroke going to be? Is it going to grow to 70 mLs? Here she is 3 days later. Her stroke is 70 mLs. So if you look at this, here she was at 24 hours. Here's her diffusion lesion. Look what happens over the next 3 days. This is not edema. Take a look again. Look at the temporal lobe. Look at the parietal lobe. This is cortical tissue going on to die. We published this in 1999. We had a big series. We published this saying strokes evolve over 3 days. Nobody believed it. Now you believe it, right? Okay, same finding. Okay, so we need to look later. We've been treating patients beyond 24 hours at Stanford. If they have salvageable tissue, we go after it. So I'm gonna finish at this point and say that time is still brain. We still have our fellows, residents, and attendings run to stroke codes. They don't walk. But now we don't say to anybody, I'm so sorry, you came in too late. There's nothing we can do. What we now say is we're going to time every brain. If there's salvageable tissue, we're going to go after it and treat it. Thank you very much.
Dr. Alberts, thank you very much. As usual, it's always enlightening. I was just curious, like I mean, obviously we're quite aggressive with the pediatric population as well here, but I was just trying to understand the rationale why you guys have a strong feeling after, Tmax above 4 seconds for children.
Yeah.
Because as you say, usually they have a robust collateral. So are you worried that they would be more prone to failure, or it seems like it would be the opposite. So I'm not sure I understand.
Yeah. So I think we are with kids the same place we were 20 years ago with adults when we were working on designing the first diffuse trial. We had no idea what the right Tmax lesion was to identify tissue that was likely to go on to infarct if you didn't reperfuse it. Our initial hypothesis in the diffuse 1 trial was a Tmax of 2 seconds or more. Right, that's what we thought. And it turned out that that's benign oligemia. Tissue with very mild delays in adults is virtually always benign oligemia unless things change and the perfusion gets worse. So what we've noticed in this dozen kids that we've done is that example, just like what I saw, if I ran that as an adult mismatch map, I would have said there's no mismatch. But yet the kid clearly has a clinical core mismatch with, aphasia, but only a mild delay in the cortical areas. And we've seen that in multiple kids, that the Tmax 6 is really small or non-existent, and there's a big Tmax 4 lesion going on to the cortex. And when they don't reperfuse, that often goes on to die. And when you do reperfuse them, it seems to be salvaged. But we have anecdotal evidence and very small number of kids. So the PETITE trial is not a randomized study. The PETITE trial is like diffuse 1 and diffuse 2. It's I want you to treat every possible pediatric kid who looks like they might have a benefit. We're going to get the imaging on all of them, and then we're going to sort through it and say, what's the best way to identify penumbra in kids? And how many of them will have collaterals that are so great that even if they don't reperfuse, they do okay?
So it gets back to clinical to core mismatch.
To get into petite, we are very generous. We even will let patients in with just a plain CT and a CTA. Our preference is trying to get perfusion on all of them. We're going to be looking at ASL because people are a little nervous about giving contrast to kids, but we're hoping to primarily get bolus contrast perfusion because ASL is harder to quantify. And we really want to know what's the best threshold to be able to predict how big that stroke will be without intervention, because pediatric neurologists are really all over the map. Some of them don't think you should treat kids with thrombectomy. They think that the kids' collaterals are so good, they're going to do great without the thrombectomy. We disagree. We think that you really do need to get those MCAs and ICAs open in the kids, but we want to be able to get the equivalent of the diffuse 3 selection criteria for kids.
Thank you, Greg. Any more questions? We're going to have Greg back later. We're going to, sorry guys, hello? Tudor couldn't make it, so we're going to save time of 25 minutes. Nima's going to just show an abbreviated version. Greg showed to us DAWN and diffuse, but a Tudor with Raul, Greg, and team have worked. So he's going to share. What the Aurora.
Thank you. Again, it's great to have Dr. Alberts here. Tudor Jovan is not only my mentor, but he's one of the pioneer. He was very sorry that he couldn't be here. He called me at 10 o'clock last night just talk about how sorry he was. But as Ricardo said, I'm just going to present this because this is new and it really fits well with what Dr. Alberts just presented. And disclosure, this is not published yet, so this is new data. Basically, as you heard, DAWN and diffuse is really what expanded the time window treatment that we do. And this is a study which is named Aurora, and I like that name. It's basically a meta-analysis of other studies that treated patients beyond 6 hours. And basically, I'm here to present this data. So in Aurora, basically, individual patients from DAWN, diffuse 3, positive, and SCAPE and revascats were analyzed. For the purpose of this talk, the positive is not included in this study, but basically, you get about 458 patients. So why is that important? Well, then you have a greater precision because you have higher number of patients, and then you can analyze subgroup. So just going through these studies real quick. So DAWN, as you may know, included 206 patients before it was stopped. Basically, it did require a very strict imaging criteria, included patients from 6 to 24 hours. Diffuse 3, 182 patients also had imaging criteria and target mismatch. SCAPE, positive, and revascats were the other trials that included patients up to 8 hours for revascat, but up to 12 hours for SCAPE and positive. How about the imaging? I think imaging is going to be an important topic going forward. And as you can see, DAWN, diffuse 3 had imaging criteria, not only just plain CT or CTA, but also perfusion imaging. SCAPE and positive did not. So here are baseline characteristics of these trials. And as you can see, the baseline, the matches pretty well. NIH is a little bit different, but overall, the site of occlusions and everything else match really well between control arm and patient who had thrombectomy in this beyond time window. And here are the results. So safety used to be a big concern, right? Because, I mean, somebody's been having a stroke for 18 hours, 20 hours. I mean, if you do a thrombectomy, potentially you could worry about a bleed. Well, if on top, this is Aurora. So these are the patients' subgroup analysis of the beyond 6 hours. On the bottom, this is Hermes. Hermes is a meta-analysis of a patient who were treated in hyperacute setting, so mostly up to 6 hours. And you can see that symptomatic hemorrhage with the acute setting was 4.4% in the intervention population. And in the Aurora, it's pretty close, 5%. So no significant difference in safety or mortality. And then how about outcome? Well, you can see that modifier ranking scale at 90 days is, again, very well matched between the two studies. And this really gives you a number needed to treat of 2.5, which is, as you heard, is a very powerful, powerful effect. Bottom line here is, if you treat the patient, if you select the right patient and you treat it, that patient benefits, whether or not they're in a hyperacute setting or beyond the typical time window. How about subgroup analysis? If you look at this, I think this is very important because we do discuss, okay, how about the patients who are older? How about the patients who have different time aspects? You can see that the treatment effect is so powerful that among all subgroup patients, there's still benefit, regardless of their age, regardless of their gender, and whatnot. How about aspect? 0 to 5 is a smaller number, but you can see that aspects 6 to 7, 8 to 10, pretty much all aspects did have better outcome, and there were trend toward better outcome for aspect 0 to 5. I'm going to skip that one. The treatment effect in clinical versus target mismatch. And this is a very interesting topic again, because the imaging criteria obviously is important. We use it. But if you look at clinical mismatch, so aspect and NIH versus target mismatch, again, the modifier ranking scale is pretty well matched at 34% for both group. This is a time from onset to reperfusion, and on the other axis you can see the functional independence. Whereas in acute setting, this slope would be really going down, right? Because later you treat the patient from onset of symptoms, poor outcome they would have. This is pretty flat graph, again, because these patients were selected based on physiological clock rather than just chronological clock. But another important point is this is time from randomization to reperfusion. So time is still brain, because as you can see, once you start randomizing, if it's delayed to reperfusion, they'll still have less chance of a good outcome. And this is significant when you look at these both two graphs. Again, supporting that even though, yes, we treat patients beyond 24 hours, again, time is brain, and we need to treat these patients really fast. And I'm going to end with these couple of slides. Basically, what these trials mean. The thrombectomy eligible patients increases the eligibility, possible at 40%. So that is great. And that's it. So I thank you, and Ricardo.
Any questions, any comments? Jens, Greg, Ryan?
It's a bit surprising that the therapy effect beyond 12 hours is higher than between 6 and 12 hours. Is it explained by a better patient selection because the population is not kind of enriched by escape patients?
One of the authors is sitting right here, so I'm going to have Dr. Alberts answer that question.
That's a really great question. It seems to be explained by the medical arm. And it's a bit of a mystery, but the medical arm patients who came in very late had terrible outcomes. Right? The medical arms in general for the Q3 and DANTE did terrible, 15 to 17% good outcome. But they did better if the medical arm patients came in early. So it's not that the endovascular arm did better late. If anything, as you showed, it did a little bit less well if the endovascular arm was treated late. But the medical arm was doing so terrible that the treatment effect gets bigger. So why could this be? Well, again, it may have something to do with the lack of the thrombolytic on board. These really late patients weren't getting thrombolytic. Some of the early patients did get a thrombolytic at the primary site, and by the time they got to the comprehensive site, it was beyond the 6-hour window, and they still hadn't recanalized. But it continues to be a bit of a mystery, but it was seen both in DAWN and Diffuse 3, which is this very bad prognosis for the medical arm who comes in quite late. Then we also have to remember that a lot of these patients in both studies were wake up. so that we really don't know exactly when the stroke occurred, and that many of those wake-up patients were, could alter things, right? So we've done an analysis of diffuse 3. It was just published in JAMA Neurology, where if you look at just the known onset time, then things don't look quite as impressive in terms of the treatment effect getting bigger later. It remains constant, but it's not getting bigger in the later window if you restrict to the people where we actually knew the stroke onset time.
Thank you. So I'm just going to ask everybody to use the microphone. I know it's going to delay just a tad the discussion. We're live streaming, so for the people that might be watching us, all three people, no, I'm kidding. All people that may be watching us, they can hear what we're talking about. Any more questions? And thank you, Abby. Second microphone, and actually you can put that on Dr. Albert's table there, and we'll have a fair division here. We use the Brazilians here in the middle as the divider. Our next speaker is Professor Jens Filler from Hamburg, Germany. He's going to talk to us about mechanical thrombectomy, many variations on the same theme. Is that a better one? Thank you, Jens, for the long trip. Dankeschön.
Yep.
Pleasure having you here.
Thank you very much. It's a great pleasure to be here, and it's a very good excuse to go to a meeting to have some sun in this time of the year. I'm from the very north of Germany. It's always rainy and ugly. It's much better here. So why did you invite me? I was wondering, why do you invite me to talk about this subject? And this is how I see the product development in neurointervention. So typically, from designing comes from some engineers doing bench testing. Then we have the pigs. Then we have Europeans. And finally, we have the Americans. And that's why I'm here, I suppose, because we are exposed to newer, maybe more risky technology. And sometimes I'm able to present some interesting information. So this is, I have learned yesterday that in between there seems to be the Australians, but this is this beyond me. Okay, so if we talk about Europe, it has obviously a very big heterogeneity. That's the number of thrombectomies per 1 million inhabitants. This is from 2015. It's now historical data, and you see the huge discrepancies. Some of the countries are really in good shape, and one of them is Germany. Actually, Germany has 80 million inhabitants approximately, so it's 4 times of Florida. But the area is only 2 times of Florida, so it's densely populated, and we did about 11,000 thrombectomies in 2017 within the German registry alone. So you can add up at least 2,000-3,000 more. That's the very good approximation. So the subject actually is there a best way to do thrombectomy? And it's quite difficult. And first we need to discuss what better one actually means. What's the parameter for reperfusion success? Do we talk about TICI-2B, TICI-3, any, or TICI-3 first pass? I'd like to discuss this subject first until I come to the actual subject. We had recently published the guidelines of the European Stroke Organization, the European Society of Minimally Invasive Neurological Therapy, ESMINT, and the therapy goal is based on this grade type review, is TICI grade 3 reperfusion. Why? But let's start with TICI 01 first. So what are the reasons why thrombectomy doesn't work? This is our own experience from our center. So we are one of the leading centers in failed recanalization. We have 72 patients, and the reasons were here: we didn't achieve access to the occlusion in 15. We reached the occlusion in 57 of these. So about 20% of all TICI 01 failed recanalizations had to do with the access. And in the remaining ones, 60% we were able to pass, but not to get the thrombus out. And 20% we didn't, we were not able to pass the occlusion. This is important if we are discussing the techniques and methodologies how to achieve reperfusion. So 40% of the cases we have an access problem, and 60% we have a device problem. We did an analysis, so we have just analyzed an academic database of about 2,000 thrombectomies, and I present just some data here. It's unpublished from the anterior circulation, and the predictors for failed recanalization were M2 occlusions and ICA occlusions, and patients with ICA stenosis, atherosclerosis. Good predictors for recanalization were if carotid stenting was actually done, general anesthesia, and if exclusively stent retrieval or aspiration was conducted. But this is obviously a bias, because if you do just one thing and you succeed, you don't switch to the other. So this is not really a very useful information. What is a useful information is this, is a recent analysis, a new grading scheme for TICI. So it's the E-TICI from David Liebeskind. And if we compare TICI 2B and TICI 3, we have a difference of about 18%. So if you achieve TICI 3, it's almost 20% better than TICI 2B. So TICI 3 is the new TICI 2B, obviously. And this is not the only paper that made this observation. There has been a meta-analysis on the same subject, and they found exactly the same thing. Twice as many patients with good clinical outcome in TICI 3 2C versus TICI 2B. And this group did exactly the same thing with more patients, and they found exactly the same. This time the odds ratio is the other way around, but they just looked at it from a different angle. But again, we have these about 20% better outcome with TICI 3. So TICI 3 is the way to go, but it's not only TICI 3, and this is something we learned from Dr. Zaidat. He did the analysis of the NASA data. And what he observed is a very important thing. If the TICI 3 was achieved with the first pass, we have a 60% good outcome. If it's achieved at any time, let's say after second or third pass, 55%. And if it's only TICI 2B, it's 44% good clinical outcome. I think this is a super important observation. And we had a look at our own data. Again, was published last year. We looked exclusively at patients that were treated or who were treated with stent retrievers. And this is a bit complicated just to show you that we did it in a very meticulous way. But the actual observation is this. This is the recanalization rate per every retrieval attempt. So with the first retrieval attempt, we achieved 45% recanalization. With the second time, 30, and then it was still with the seventh, we still had 25%. But was this clinically useful? This is a bit more complicated. What you see here is the accumulation of the retrievals and the reperfusion. So finally, we ended up with 75% or 73% reperfusion rate. And the rate of good clinical outcome went up also in cumulo. But if you look at this curve, you see that beyond the third retrieval, probably there is no additional therapy effect. You have good chances to reperfuse, but not to improve the patient. And I think that's a very interesting observation that has been confirmed by others, have been papers published about the same time. And if we look at the German stroke registry, again, this with 1,800 patients, we had a look at the same question. And what you see here is that with the third retrieval attempt, again, you still have an improvement of clinical outcome. And you might guess that beyond the third retrieval, there is still an improvement in clinical outcomes. So the statistical analysis is not concluded so far, so I can't show you for sure. But if you look at the odds ratios for every retrieval here, first retrieval success, second retrieval success, third, you see that the chances of good outcome are decreasing. And again, it's absolutely clear for the first three retrievals, but with the fourth and fifth, it's a bit more difficult. I suspect if we put them together, there's still a marginal therapy effect. So probably it's not a very valid message to say, okay, after three retrievals we should stop. Probably it's better to still try and attempt another recanalization. So what is the best technique to achieve TICI-3 at first attempt? That's the real question here. And there are different techniques. And I think it's really confusing. I heard Sam Zaidat once say that in the NASA registry, he identified 40-something different methods to do the thrombectomy. And I think it's easy to start with a regular thrombectomy, like in the old days, with a stent retriever and more or less nothing else. And then it became more popular to use a balloon guide catheter together with a stent retriever. Then we had the emergence of the ADAPT technique without balloon guide and without stent retriever. And let's have a look at these techniques first. So this is, again, an analysis of the NASA registry. And they compared the typical basic approaches: balloon guide catheter, distal access catheter aspiration, and without a balloon catheter, regular guiding catheter. And if we look at these data, it's quite convincing that with the balloon guide catheter, we have the highest number of patients with a very good reperfusion result. And it's not so, it's in the middle with the intermediate catheter, and it's much lower if we use a regular guiding catheter. So we shouldn't do this anymore. But is this clinically relevant, which is the key question? And yes, it is. Like what you see here with the reperfusion, the same is true for the rate of good outcome. If you use a balloon guide catheter, it's the best result. So again, here the data-wise, what you just saw here, and the first pass success is much higher if you use a balloon guide catheter. There were surprisingly no differences in the embolization rate, and we have did a small analysis of about 30 patients where we used high resolution diffusion weighted imaging after the procedure. What you see on the left is standard resolution, and on the second image, it's high resolution. And if you look very closely, you see there's more going on. It's more noisy, but you see more with the high resolution DWI. And we found, I go over this a bit quickly. What we found is there were distal emboli in new territories, even in patients that were classified as TICI-3. It's rare, it's about 10%, but at least it's there. And as you would expect here, in TICI-2B, more than 60% of all patients had small distal emboli. And it's in this small cohort, it was not clinically relevant, but we are working on this to find a connection if there is one. And if we look at the materials, again, it's the same observation. If we use a balloon catheter, we have the lowest rate of small distal emboli. So balloon guide catheter is really something very useful for different reasons. So let's go to the ADAPT technique. It was first described in 2014, published. So it's a direct aspiration of the clot without the stent retriever. And the French were very early and did a randomized controlled trial and compared the aspiration with the stent retriever, and the results were not super good. So they had a primary recanalization rate with the contact aspiration in 63% and 68% with the stent retriever. And then after switching to the other technique, it was almost equal, and there was no real difference in clinical outcome. but it's really hard to understand what this actually means. And I'd like to explain you why. Let's assume you have a study result like this one from the ASTA study, aspiration 63% primary recanalization, and central retriever 68. But what does it mean exactly? Let's say in one center you have a stent retrievist. This guy knows exactly how to use his stent retriever. 73% good recanalization with a stent retriever, 56 with aspiration. And let's assume in another center you have a 17% difference. And then you have an aspirant or an aspiratrice interventionalist 2 in another center, and she knows exactly how to use the distal access catheter and has better outcome with aspiration than with stent retriever. And the final difference of the randomized study is exactly this result. So what do you do with this? And it's getting even more complicated. If you do a study where the major part of the centers are stent retrievists, like in France here, you have a very predictable outcome. But if you have a different selection of centers, it will be different. And let's say one is in 2012, one is in 2017, you will have a different outcome. It sounds very theoretical, but some guys in the US knew this already while they were designing the COMPASS trial. And they had a center preference that was balanced. So 6 centers had a preference for ADAPT, 6 for stent retriever, and 3 no apparent preference. So what was the result? The result was very similar results in both groups. So TICI 2C or 3 within 45 minutes, TICI 3 within 45 minutes was even better with the aspiration than with stent retriever first. And there were other interesting observations, like for stent retriever, the vast majority of procedures were done with distal aspiration additionally. And more than one stent retriever was used in 13% of the cases, so bailout procedures. And stent retrievers were used in the ADAPT group additionally after initial failure in 21%. This is the timing. So if aspiration works, it works quicker than stent retriever. That's a very interesting observation in COMPASS as well. So it gives us a lot of reassurance that aspiration is something that could be done. So, but it's not only aspiration. We were just discussing this one here, which was a bit mixed with the other techniques, and I just make this very quick. And we have the first author of the captive paper sitting here, so he explained much better where I have no understanding. But I think there are subtle differences between these combined therapies of balloon guide catheter, yes, no, majority don't use it. Distal access catheter is used by every of these techniques, and microcatheter also, but the way it's used is different. Some use it to actually to retract the clot in half into the distal access catheter, some in total, and they have different results. So this is a nice drawing where you can see the differences here. So you have the father of all these techniques is called the solumbra, so the solitaire and the penumbra together. It was used primarily to anchor the stent retriever and use this to get the aspiration catheter up, but the new and modern aspiration catheter don't require this anymore. So it's more or less an ancient technique, and we have the ARTS technique where a balloon catheter is optional, can be used, and the SAFE technique, for instance, they don't do the balloon guide catheter, but they do a good aspiration here, and they were the first ones, as far as I understand, that pioneered the wedging of the clot into the distal access catheter, not retrieving it in full. And we did an analysis with 5 German centers here, 450 patients, and compared just very easy combination therapy versus aspiration alone versus stent retriever, and the outcome is actually what you would expect. Combination outcome has the best reperfusion rate. But there are further advances. This is a very recent publication, the Protect Plus technique, where they did everything you can imagine. You have a balloon guide catheter, and you do an aspiration additionally to the inflating the balloon. You make an aspiration here, you do an aspiration here, you wedge the clot into a distal access catheter, and the results are very good. So they have, but yeah, I come to this point a little later. And this is also a recent paper where it was essentially a survey who did what, how, and you see it's not so easy to understand at the first glance, but it's what you see, there is still a huge heterogeneity between the centers, and I suspect even within the centers, and it's additionally dependent on the patient, the specific anatomy, and I think it's going to be very difficult to come to a very standardized procedure. But what we see here is with the Solumbra technique, I didn't do a proper meta-analysis here just to give an impression that we have first pass TICI-3 with the Protect Plus technique I just explained, 74%. It's a super high rate. It's very encouraging, and it's very similar to the SAFE technique. And ARTS and Solumbra are a little bit behind. Captive, I didn't find this rate, but probably it's also super good. Just as a last point, last subject is permanent stenting. So there has been a period in the development of thrombectomy in 2006 to 2009 where people published some small case series where intracranial stent was deployed like a wingspan or an enterprise stent, and the results were in the region of thrombectomy, but small centers, some of small series, some of them retrospective. So, and when stent retrievers came, this technique was abandoned. But during the last few years, we have an increasing amount of papers that discuss the permanent stenting again, but only for patients where you have an ICAT as the pathology. So this is just to see here, the rate of TICI-2B3 is not super high, but the rate of clinical outcome is in the region of the Hermes data. And this is also really hard to interpret, but some of the papers also published the outcome without stenting in patients where it was avoided. And what you see is if you look at these red numbers and compare them with these numbers, it's much, much better to do the permanent stenting than not doing it. And there has been a publication by a group from Korea, and they found the same outcome in patients where they did stent or where they had to stent because of underlying intracranial atherosclerotic disease and without. And we collected data from more than 200 cases from predominantly Germany, but also from Sweden, Korea, and we were able to do a multivariate statistics with these data because we have the patient level data. And the good outcome was 44% in these cases. And the predictors of good clinical outcome were the usual suspects, but again, TICI-2B or 3 was a very important predictor again. So if I may summarize here, TICI-3 at the first pass maneuver is the new goal for us. So techniques matter. So it's not everything the same. So there are differences. But if you really want to study the differences, it's very, very difficult, even with a randomized trial, to do it in a proper way. It's very challenging. But the overall trend that we observe is to put all ammunition into the first retrieval to achieve a first pass TICI-3, so combined balloon guide catheter, intermediate catheter, and stent retriever. And acute stenting in selective cases is re-emerging as a bailout procedure if we have a failed reconization. Thank you very much.
In the cases of acute stenting, what are you guys doing for antiplatelet therapy afterwards?
Yeah. Very good question. So what we are doing, we are able to give IV aspirin, and we add GP2B3A antagonists.
And you do that immediately during the procedure?
Yes.
Have you been using integralin?
Exactly.
We have a protocol, sorry, Greg, just in the same direction. We have a protocol running, Eric, with Cangrelor, and we're hoping to get this approved through our pharmacy. The beauty of Cangrelor is 30 minutes is out of the system. So Cangrelor is a IV equivalent of Brilinta. So I think for this type of patient specifically, when you have to do acute stenting, that you're worried about a hemorrhagic transformation again. These patients, off 30 minutes, you can be cutting during craniotomy or whatever you need. This is out of the system. So for this specifically, I think it'd be great. Go ahead.
Can you do that immediately?
This was obviously the key question, and I don't know it by heart, but the hemorrhage rate in these more than 200 patients was something like 8 to 10%. It's a little bit higher than in Hermes, but not in a way that you are really afraid. So,
when we published with the LAD series with the wingspan for primary and for enterprise later, highly selecting on CT perfusion, the hemorrhage was not an issue. So I think the case selection, and that's my question to you, Jens. When you're deciding to jump the gun, you show like 3 passes and then the failure rate after that. So when you're deciding, okay, enough, and I'm going to go stent this lesion, because I thought we could look at the lesion. There's an intrinsic. We have a protocol running here. I gave up trying to figure out if this is clot stuck to the wall, or if there's that through there. Decide to jump the gun and stent.
Yeah, that's a very good question. It depends on the age of the patient, on the size of the infarct, on the location. Everything gives us the impression that we should do it, then we do it. So it's multi-variable decision making.
Do you have any information from your review, or do you have any thoughts of knowing ahead of time what type of thrombus you're working with in these more than 200 patients and what impact that might have on your choices?
That's also a very good question. So there have been few publications out also from the Koreans where they try to predict if it's an ICAT or an embolic occlusion based on the location. They call it, I think, the truncal type, but it's not super reliable, and it's still a matter of feeling. So some of the indicators also include, let's say, if you have a patient with a proximal occlusion and a comparably low NIHSS, this could be a sign that it's a pre-existing stenosis. This is one of the factors.
No, I completely agree. What I was really referring to is you have a thrombus and emboli, but it's red blood cell rich red thrombus versus white blood cell platelet rich, which we know are harder to retract. When you did your analysis, did you have opportunities to know how often it was a red thrombus, easy to take out, where you had first pass to Key3, versus how often it was white thrombus? Not so much the concern of ICAD, but you're truly working, but you know you have the more difficult thrombustry. Is there any information from your study about that?
Unfortunately not. This is a large database that doesn't have this detailed information, but we are currently trying to collect imaging data to make a lot of these analysis. But generally, the white clots are much harder to get out. That's no doubt with that.
We have some data. It's coming Walid and David Combs from Mayo, they coordinate what is called the STRIP trial that we will collaborate. It seems like you can detect this red blood cell rich. They'll be brighter on the CT, and correlating that with the pathology of the clot, on the rich red blood cell clot, the recanalization rates are higher. That's what seems to be what's come on the strip. We are part of a registry now of 1,000 patients, excellent trial using the old Neravi, now Cerenovus stent retriever, analyzing the clot in every single pass. So first pass, second pass, every time you pass, you collect that. Ryan has a question. I have a question for you. You can think about them walking there. When you jump to do a direct rug puncture, we have this discussion internally all the time. You show 70 patients with fail, many of them access. When in Hamburg you say, okay, I'm going to puncture the carotid, I cannot get access through the radius or through the groin.
Actually, never. Maybe we are afraid of these arteries, but yeah, we do radial access now. There's also a study starting where we do this more and more. So, but we are, let's say, very conservative generally, because we are also a teaching hospital. This also explains our comparably low reperfusion rate. We have a lot of people who run through, and it doesn't make things better. So we tend to be not so artistic.
Yeah, I had the pleasure of doing that last week, but it is the exception. But to echo your comment, I mean, I think there is a little bit of technique that can be drawn from imaging. And for example, if you were to do an MRI, if you have blooming on the gradient echo, you know that's probably red clot. You know that, well, maybe I'll try adapt on this because it'll get sucked out. Multi-phase CTA, on the late phase, you'll outline the proximal margin of the clot and the distal margin of the clot. And if it's short, then you might say, hey, I'm going to try adapt in this situation. That said, I think it's not a good policy to try to pontificate and strategize as to what technique. Pick one, and I will tell you that we throw the kitchen sink at it. So we use the balloon, we wrote the captive paper, but it's essentially the Protect Plus. So we use a balloon guide, and you'll hear a little later in my talk, we use a stent. It's the best of the stent retriever world. It's the best of the aspiration world, and it's your best chance of getting first pass. So I think you can use imaging to sort of strategize your approach, but I think it's better to just standardize and throw the kitchen sink and get it out and get out of there.
Any more questions? The next, I think we're going to give two of you, I don't know how you guys are going to arrange that. Can you bring the boxing gloves, please? We're gonna give Greg 10 minutes. Jens has very kindly volunteering last night at dinner to, you are doing this, right? So Jens has volunteered to take Tudor's place. If not, Eric would take it, but Eric had to run back to me. We had not debate if Eric was doing for Jens. So Jens is going to cover for Tudor. What are we doing in the image? Do we really need to do all this advanced image? And if you look at what we just learned and saw on the Hermes, Aurora, and everything that we know, do we need advanced imaging or we don't? So Greg, too little or too much? Greg is the too much guy. Defending that we should image people, and Jens is going to defend that we just need a plain CT. We don't need anything else. So fight is on.
Too much guy. You said, so you never told me when you asked me to give this talk, was I too little or too much? Too much would be we don't need to do imaging. So that's the less is more approach. And I was thinking about doing that, but I figured, what's Tudor going to do? And you would think that Tudor might say you need imaging because his Dawn study was an imaging-based study. It was a huge home run. But in any case, let's see what we can get to here. Just to go over disclosures, we developed the Rapid software at Stanford over many years, and then it was sold to SchemaView. For Medtronic, at the time they were Covidian. We were running the penumbral imaging core lab for Swift Prime. And then I'm the PI for the Timeless study, which is the TNK versus placebo trial that we talked about earlier. And that is being sponsored by Genentech. Okay, so I'm going to talk about too little imaging, that there's too little imaging. We should do penumbral imaging in most of these patients. And the lawyers have a term called res ipsa loquitur. Do you guys know what that stands for? Any law students here? I think it directly translates to saying the evidence speaks for itself, okay? So this is the results of these modern thrombectomy trials looking at the absolute benefit. And you can see we've had a number of positive trials, but the ones that have big benefits, very large benefits, are the ones that did perfusion imaging. So this is a little introduction to the idea that I think perfusion imaging has a lot to offer. Yet there have been criticisms, and I suspect we will hear some more criticisms today. During most of my career, I was criticized because my trials did not produce very good results. And now I'm being criticized because the trials I've been involved with have results that are too good. So you just cannot win around here. And specifically, people are very focused on the NNT from DAWN and Diffuse 3, saying, wow, an NNT of 2 or 3, that's bad. That is a bad NNT because it proves you're excluding a lot of patients who could benefit. So we're going to talk about what the NNT should be. And then sometimes we hear people, tutor, for example, say endovascular therapy can be futile, but never harmful. So we'll talk about that a little bit too. So what's the optimal NNT? Well, it depends on what you're talking about in terms of the intervention and the outcome. For example, if you're looking at preventing death from jumping out of an airplane, your NNT for your parachute better be 1, right? If it's not 1, we're in trouble. And if somebody came out with a new parachute, new AI developed parachute that had an NNT of 2, it would not sell well. It would not be a popular parachute, right? So NNT, anything other than 1 doesn't fly there. But if you're talking about Plavix versus aspirin for secondary prevention of stroke, the NNT is 200. So you can debate about how cost effective that is. But if you had a new agent, new fancy ticagrelor type drug that had an NNT of 50, that would be fantastic. That'd be amazing in that setting. It'd be a big hit with an NNT of 50. So what should be the NNT for endovascular therapy? Well, let's think about this. We know a lot about the pathophysiology of stroke. And if you have a large penumbra, you're going to get a small NNT. If you have a small penumbra, you should still treat the patient, right? The NNT won't be quite as great, but you should still treat them. But if you have no penumbra, my argument would be that we don't want to reperfuse people with no penumbra. This is a resource-intensive, expensive procedure. And if there's nothing to save, why are we perfusing the patient? And then, more controversial is this issue that I have seen patients that I'm pretty confident were harmed by this procedure. And I think when you ask people who do it, many will admit that there are patients who did not do well because of this procedure. So who are those patients? I think patients with massive core and no penumbra are in there. And if you're treating all those patients, then your NNT is way too large. So what you really want to do is treat the patients in the green category. And if you include all the green patients, you should have the optimal NNT. So now is the question for the audience. What is the optimal NNT for endovascular therapy? I've got 3 choices, 2, 5, and 10. How many people think 10 is the best NNT for this procedure? How many people would go with 5 is the best NNT for this procedure? And how many people would say 2? Okay, there must be a lot of other choices because we got a few low hands over here, the periphery of the room. The penumbra was not voting. The core was saying 2. Okay, so let's think about this. And this is, I think, a perspective that many people don't think about when they tell me that the NNT of 2 or 3 is way, way too low. So if we asked you, our endovascular folks, what's your TICI 2B3 rate? I think a reasonable number we might get from the crowd is 80. Would you agree with that? Yeah, 80. So if 80% of the time we have substantial reperfusion, shouldn't close to 80% benefit from our treatment? Good outcome rate in Mr. Clean was 33%. Okay, so I think a lot of patients should benefit, and I think that this is a phenomenal procedure. It's incredibly effective, and we should not accept large NNTs. And in fact, if you do the math and you say, I'm going to reperfuse, substantially reperfuse patients, and absolutely agree, TICI-3 is way better than 2B, but 2B is significant reperfusion. If I brought 40% of the patients to the lab with salvageable tissue, and I reperfused 80%, that'd be an NNT of 3. And I think we should be able to do a whole lot better than 40% of the patients that I send to the cath lab having salvageable tissue at the time of reperfusion. What if 50% of the patients that I sent to the cath lab had salvageable tissue, substantial clinically relevant salvageable tissue at the time you pulled off that TICI-2B3? That NNT would be 2.5. And if 60% of the patients had salvageable tissue at the time of reperfusion, that NNT would be 2. So this is why I don't like the idea that we should accept the NNT of 8 from Mr. Clean. I think we should be heading to 2. And I would like to even be better than 2. If I can reperfuse 80% of my patients, I would love to have 75 to 80% of those patients benefit. All right, so we go back to where we were in the earlier talk and say the world exists of patients who have salvageable tissue and can have big benefit. Some who have less salvageable tissue can have small benefit. And this red zone of patients who I believe are harmed or at minimum have no benefit. So these are patients with massive core, they've got no blood volume in the stroke, or they've got no penumbral tissue. And even if you have a neutral to negative effect in that red zone, you can still have a positive trial, right? Because the green and yellow zone is bigger. So if I treat all of these patients, I'm going to still get a positive trial because the benefit is so huge in the green and yellow zone. Does that mean I should treat all the patients? Some people say yes. I don't think so. If we can clearly identify who's in that red zone, why are we doing a resource-expensive procedure? But just the point is that you're going to still get a statistically positive trial when you mix in patients who don't benefit if a substantial number have a huge benefit. And we have a treatment that has a huge benefit. Okay, harm. So one of the reasons that we hear that there's no harm is that when you look at the Rankin 5 or 6 rates from any of these trials, you don't pick up harm in the overall trial. But just as we've discussed that there's people in different zones, you can have 15% of your patients in the red harm zone where you actually increase death and disability by maybe 20%, but mix that in to all the good patients who are having a substantial reduction in death or disability, and you can wind up with a neutral or slightly positive risk reduction on death or disability. Does that mean we should treat everybody? No, we should identify who's in the red zone and not treat them. So who's in the red zone? Let me give an example of Mrs. Jones. 58-year-old woman. She's one of these typical patients where you don't really know when the stroke occurred. Technically, she's a wake up, but the story was that at 7:15, she was doing some of her normal activities, but we don't really know when the stroke began. She can't tell us. Her NIH is 13, her aspect score is 7. She's got a right MCA occlusion. So she may be early window, she may be late window, but her aspects is 7. Should we treat her? How many say yes? Okay, a lot of people say yes. How many people say no? She could be late window. We don't treat late window by aspects of 7, but what if we got more information? So here's some more information, a CT perfusion that says her core estimation is nearly 200 mLs, and she's got no blood volume in her infarct. She was treated. The hope was that after the procedure, this was a lot of contrast, but it was blood. So she was harmed by this procedure, in my opinion. And we've seen people harmed by this reperfusion in the past. Diffuse 1 in 2006, Diffuse 2 in 2012, no target mismatch. The reperfused patients did worse than the non-reperfused patients. And here in 2018, the SELECT trial, which took a big cohort of patients, got CT and CTP, found patients who had a good aspect score, just like Mrs. Jones, but a bad CTP, their mortality was 50%, their symptomatic intracranial hemorrhage rate was 25%, and if their core was over 100 ml, their mortality was 70%. Contrast that with the patients who had a good CT perfusion, but a bad aspects. They had a low aspect score, but a good CT perfusion. These patients did quite well. So here it is graphically. On the right, unfavorable CTP, but a favorable CT, just like Mrs. Jones, very unfavorable profile of outcomes, whereas the patients who had a favorable CTP, even if the aspects was low, they look like the patients who had good CT, good CTP. So too little, too much. Get enough so that you know who's got salvageable tissue, and try to reperfuse patients who have completed infarcts or at very high risk for reperfusion hemorrhage. Thank you.
Thank you, Greg. Dr. Filler, if you can do in 10 minutes, it's the first point on your direction.
So I'm acting here as the poor man's tutor. And this is my only chance to not being tutor. So no real conflicts of interest here. American Heart Association guidelines say basically, if we start here, it's a bit of a cheap trick from my side, is that all patients admitted to hospital with suspected acute stroke should receive brain imaging evaluation. In most cases, non-contrast CT will provide the necessary information, and multimodal CT or MRI should not delay administration of IV alteplase. But in the 6 to 24 hours time window, there is a clear message that we should do CT or MRI perfusion imaging. The European guidelines that I already mentioned here say essentially the same thing, but they are a bit more undecided. They say advanced imaging is not necessary, but it doesn't say it should be avoided. And obviously, it's also important in the 6 to 24 hours time window. And I fully agree with Dr. Albers here. This is an analysis that we did for these guidelines, and it actually shows what you know already, that if you use a collateral imaging patient selection or perfusion imaging selection, the benefit of thrombectomy is higher than if you don't select your patients with these advanced methods. So no doubt about this. But again, I think my major line of defense is I'm one of the thrombectomy doesn't harm people. And if we do advanced imaging, we exclude a substantial portion of patients who may benefit even without a clear target mismatch profile. So I think we need, the question is a bit blurry. Do we need much imaging or not so much imaging? I think first we need to frame the whole thing or phrase the right question. What are our expectations? Do we want to achieve a good outcome? I think this is very important. If you start with the procedure, you are new in the game, and you need to deliver good clinical outcomes. Or do you want to achieve a high therapy effect, which is a different thing? Some economic restrictions, or would you just say, I'm happy with any potential therapy effect as long as I do no harm to the patients? Of course, it requires a low complication rate. It's nothing for new centers, and economic incentives are also important. So you end up either with treating few patients with high effects and good outcome, or just more patients with still a relevant outcome, or treat more or less everybody because there could be a chance that it's useful. And I'm a bit sad that I give my presentation on large infarct core this afternoon, because it would have helped me a lot in my talk here, because I actually think that in large infarcts, we have a huge therapy effect, even if it's really big. So again, just to make my point absolutely clear, if we have a super target mismatch pattern like on the left side, if we have a persistent occlusion, we have a full MCA infarction, and we avoid this by recanalization, a super success. Instead of MRS 5, we have MRS 0. In the middle, or let's start with the right side, if we have a complete MCA infarct, I absolutely agree. If everything is dead, there is probably no point to reperfuse. But the question is, where do we have the threshold here? And this sub-radar success brings the patient from MRS 5 to 3, for instance, just for the sake of the argument. And obviously, good outcome, bad outcome, but in between, is this still a bad outcome? This is the good therapy effect. So what modifies our expectations, the skills and infrastructure? Let's say if you belong to the lucky few, I think this is the center in Chicago from Demetrius, high-end imaging available all the time, super radiologists, and this is the majority is probably not exactly there, and this is my hospital here in Hamburg, and we have old non-enhanced CT radiologists have a bad mood all the time, are not interested in stroke, and this is, I think that's difficult. And I think this is exactly the place where if we have an automated image analysis system like the OLEA or Rapid, I think that's exactly one of the places where it should be done, because it makes it generates a bar where you can jump over and say, okay, the system says go, and then we go. And again, the same story here, good outcome, good therapy effect, potential therapy effect. And this is connected with the situation that you encounter with the radiologist. And this is, it looks a bit complicated, but it's essentially says the more you can do without the high-end imaging, the more resources you need. So you replace resources from the people side with the software in specific situations. Just some more points regarding the image analytics. So this is an analysis of the more or less Hermes data, and they found what's expected, that increasing ischemic core was associated with reduced likelihood of functional independence, but the mismatch volume was not associated with functional independence or functional improvement. And the core volume, now it's getting really interesting, was independently associated with functional independence. So the larger the core, the poorer the outcome, but it did not modify the treatment benefit. And it really depends on the way you analyze this perfusion imaging to actually show this. This is a bit complicated, but it's just illustrating how the different outcomes, or the probability of good outcomes and the risk differences are modified by your expectations. If you want to achieve just modified ranking scale 0 to 1, you have a different curve than 0 to 2, dependent on the volume of the ischemic core here. So it's actually very important what you expect and what you want to achieve with your imaging. And I personally don't think that there is a absolute threshold, and it's based on I'm convinced that we actually harm very few Mrs. Joneses here. There. So stroke imaging, 0 to 6 hours and 6 to 24 hours. So we all agree that the proof of occlusion is mandatory. Define your terms, core is king. We need to know how big the infarct core is. It's very important to differentiate between good outcome and therapy effect. and know your limitations, your local situation. I would call it reading aid. There are also the Brainomics software for the aspect score. But in the end, I'm really very positive and very optimistic that we will have a therapy effect even in very large core patients. And as you already mentioned, Dr. Albers, in your previous presentation, time is brain, but there is no absolute time limit. I think that's super important to re-emphasize all the time. So, vielen Dank.
Okay, questions, anybody? Okay, I'll start then. Sorry, Eric, I'll let you go first. You're a guest.
I just got a question for the audience, more like a polling of what people are doing despite the guidelines out there. Like, you know, who here, like how many people with show of hands are still doing CT perfusion in patients within the 6 hours? All right. So the next question is, okay, so now we have guidelines that are telling us that we're supposed to ignore that. Okay. When you look at, you know, the guidelines saying that if you're doing, what's that?
Guidelines have been rescinded, right? So remember there was 12 guidelines that the AHA put out and then rescinded. One of those 12 was the one we're talking about. That is no longer in effect. That do not do perfusion within 6 hours. So, but it's not. They still were saying not recommended. So they take that one. Everything is in the ether right now. Right? Remember, the guidelines were incredibly. Yes, Dr. Powers put out a different group of guidelines, and then about a month afterwards, the AHA rescinded 12 of them. So we're waiting for them to come back in. So right now we have no guideline about, you know, do not do perfusion imaging within 6 hours. And granted, a lot of people don't do it, but it's not because of the guideline that's in effect. The guideline is currently in the ether, waiting to come back. All right, no, because, you know, to me, it puts us in a really bad spot. You know, whether CT perfusion works or doesn't work. You're saying that it works if it's greater than 6 hours, but it doesn't work or don't use it. And I'm a firm believer of CT perfusion for all the reasons you guys said here. You know, we want to know if there's a core or not, is there salvageable brain or not, and how much it is, because that's what's going to guide good outcomes.
May I add something here? I think we focus here very much on patients who actually receive thrombectomy procedure and who are enrolled in the trials, but there are many other patients where it's really difficult to understand what's going on. And in these patients, I think CT perfusion is also very valuable. And it's difficult to say, in this patients we don't do it, in this
overcall the core using frequently for is not to say who's going to the cath lab. It's to figure out what's wrong with the patient.
Yep.
And our patients, when the paramedics call, we don't know anything about them. We don't know when they were last known well, like Mrs. Jones, was it 7:15, was it last night? We have a huge benefit if you go straight from the paramedics into the scanner. And if you get all the information at once, it's, again, a huge benefit. So we do this CT perfusion to figure out who's having a stroke, who's not having a stroke. It informs our IV TPA decision. If somebody comes in, they can't talk, but their cortex is normally preserved, that's a stroke mimic. I don't want to push TPA into that patient, right? And if we come in and we find, patients who don't look classic for a stroke, but they've got an M2 occlusion in their right parietal lobe, suddenly they're a TPA candidate, even though their symptoms were atypical. So I think it's extremely helpful to figure out what's wrong with Mrs. Jones, rather than does she need to go to the cath lab or not.
Yeah, I couldn't agree with you more. I sorry the word. I think it's idiot proof. The green and pink, I think it's phenomenal. And it creates a big brother. We're all here watching Nima. Actually, Eric is talking to the patient. Nima and I are looking at it and said, M1 occlusion, who's on call? So, and Eric stands up when I'm looking at Nima, Nima look at me, Eric is standing up and leaving the room. So we're not even on call when we know what's going on. So I think from the system perspective, I think is phenomenal. My question to two of you and Ryan, whoever else wants to jump on that, who you don't take to the cath lab? So you show Mrs. Jones. Mrs. Jones on the early window, I'm taking Mrs. Jones to the cath lab. And if she bleeds, sorry, we tried. But this patient is wake up, I don't know. You have that CTP with an aspect of 9. Would you take that patient to the cath lab, Jens?
So the reason I wouldn't have taken her,
you would or would not?
I would not, because she had no blood volume in her infarct. And that we've never seen a case who has no blood volume, right? So you talk about your early window patients that they can be, we can have core overcall, ghost core. When you have no blood volume, it's like a cardiac arrest of that zone of the brain. And I've never seen one of these dark blue, 0 blood volume patients do well. But I absolutely agree. Those radar patients, I think they can benefit too. The question is, how do we find those below the radar patients? Is the aspects going to be enough, or do you need to know that they've got a penumbral area? I think you need the penumbral area.
So before Jans answered that, going back to your blood volume, this is our early experience, and we discussed this before. Blood volume in our early CTP experience seems to be more predictable, a better predictor, to better phrase, than blood flow. But on rapid, we use blood flow. So is there any way that we could add that blood volume? Because again, if you see a black hole in the blood volume, you know the brain is dead.
Yeah. So there's blood volume maps that come out automatically. The CBF comes out first. And the reason that we do that is because we did a number of studies looking at take patient from CTP to MRI scan. What's a better predictor of the final infarct and complete reperfusers? And CBF did a little bit better than CBV. CBV still did well, but oftentimes if you've got very good collaterals, that CBV may not be as predictive. So in the ultra early window, we're very aggressive, right? I mean, somebody's coming in a half hour after stroke onset, there's practically nothing that's going to prevent me from taking the patient. We've had 2 patients in our history who had a stroke while on the scanner. And you can imagine if you immediately occlude a vessel, that CBV and CBF can go to 0 very quickly before collaterals kick in. So, I just don't see that many of those patients, but I'm going to be very aggressive early. But somebody 4.5 hours with no blood volume and a big chunk of brain, we've done it and we've regretted it.
So early window and late window, so up to 6 and 6 to 24. Who you don't take to the cath lab, and yes, who you don't take to the cath lab?
I think important information is the age, the biological age of the patient, and the actual size of the infarct. And if it's a young person, let's say something in the 60s, I would do it whatever aspects and CBV looks like. In an older patient, it's a different story. So there's a very, very high threshold for us not doing thrombectomy in the patient. And I think the problem is I we agree obviously too much. It's a pity. Sorry for you. That perfusion imaging is super interesting and should be done in every patient. But I would be very reluctant to decide not to do thrombectomy based on perfusion. And you mentioned CBV 0-ish, but we don't know how long it's there. It's a stable situation. It's a dynamic process, and but I would be very reluctant.
So 75-year-old female, last seen normal 20 hours ago, aspects of 10 with 100 cc's of core, no CBV, 0 CBV on that area. Would take this lady?
In what
aspects of
100 milliliter CBV 0, no problem. Yes.
Greg, would you take her?
Are we crazy? This is why we need trials. I mean, we have wonderful discussions every Monday at Stanford about, did we make the right call or not? And these are very tough cases. We make these rules for the trials, like the diffuse 3 criteria got us through the trial, but we don't follow that to the letter in clinical practice. The age is incredibly important. These very elderly patients in their 90s, once they get an infarct volume over 50, you're not seeing a lot of good outcomes. And we really debate about, did we do the right thing, taking somebody with an infarct core of 50 or 60 who's in their 90s, in their dominant hemisphere. Very rare to see good outcomes. Those are not patients well represented in these trials. The elderly patients in the trials are the cream of the crop with perfect Rankins before their stroke. That's not what we're seeing. We're seeing these Rankin 3 or Rankin 4s, the families begging and pleading to do the procedure, and it's a disaster, right? So we need these trials to sort out the answers to these tough questions.
I think one point that I want to make, we have to go have lunch, because if not, the guys are going to get mad, because we're going to start sharp at 1 p.m. We have a big crowd represented here that are from Brazil, and CT perfusion is a luxury there. We have plain CT, and if we are lucky, we have a CTA at the ER. Raul Nogueira and Sheila just complete resilient, you guys are aware, and it's a positive study, so hopefully that will force the Brazilian government to pay thrombectomy. Just to give an idea, 70% of the patients in Brazil are government patients, so they don't get access to thrombectomy in 2019. So if you come to the ER at Dr. Marcelo's hospital, government doesn't pay for that. And they don't have CTP. So I think for Brazilians and outside of the world that they have the hospital that Jens demonstrate that, plain CT and CTA is fair game. I think ideally, especially later windows we need, and I think it helps us decide who to treat. But if you're in the middle of nowhere, with all the respect to my Brazilian friends, if you are somewhere that you don't have this, I think this is fair game. Good aspects and the vessel occlusion, go for it. Mr. Clean supports that, and Aurora supports that. If you're in the middle of nowhere without CTP, ideally you have that. If you don't, go for it, because you have a good chance of helping this person. So I think it's a great discussion, and I don't know if you would add anything to that, Jens, or these situations that we don't have CTP.
Yeah, I mean, half of the resilient sites did have CTP, so that was given to them as part of the trial. It'd be really interesting when we look at the resilient results and the CTP centers versus the non-CTP. Obviously, we want to treat these early window patients. If you don't have CTP, you can get by with a CTA and an aspect score. But what I'd like to see is also what you alluded to. It's the primary centers who need to start doing this for the late window patients, because right now we have a huge number of futile transfers. Those are incredibly expensive and very frustrating for everybody. We've got about half our referral sites that do CTP. We know who's got salvageable tissue. We know how much it's going to grow during transport. We don't take patients that we can't add something to. Our other half, they don't. And a high percentage of those patients who come in late window, there's nothing for us to do. And we've just spent a fortune transferring that patient to Stanford. So I think as we move to the future, we need to make CTP more accessible to those sites, because it's really going to help improve the triage.
Yeah, we were on the first here at Baptist, and Nima published on that. I think it helps a lot, the triage process, keep these patients away from the mothership, because we are overcrowded. There's no question about. One last one, a tutor would not be happy if I don't ask you that. If tutor were here, he'd say, baloney, we should just do a plain CT, take the patient with a high NIH, plain CT, straight to the cath lab.
Tudor would say, skip that CT, take everybody straight to the cath lab. So we need to do better imaging in the cath lab. Our people think that's kind of an unusual approach. Our cath labs are very busy. We don't want to get a lot of migraines and postictal patients into our cath lab. We want to screen them in the ER. But there are more advanced imaging that can be done off the C-arm. You can do perfusion, you can do cerebral blood volume, you can do a better plain CT. So if you're going to follow that Tudor procedure, let's at least get good C-arm based imaging.
What about you, Jens? CT, skip CTA, go straight to the cath lab. You're there, you have a catheter.
No. that would be too much. But I just would like to add one thing with these debates, and we need to be aware that we all have a lot of assumptions, and usually typically from our own situation. So I'm coming from a metropolitan area. You too. We have quite a few resources, I think, but it's super different. If you look at Europe, there are different needs, and this is something we always need to consider because there is no real answer. Too much imaging, not enough imaging. It really depends. Sorry.
I think great discussion. I just have a quick question. So let's say if a primary stroke center gets a CT perfusion and then gets transferred to the comprehensive center and has a good mismatch and low core, but it's like 2 hours delay of the needle puncture or going to the clot. How sure we are that that same CT perfusion, which happened 2 or 3 hours ago, still applies to the patient at the point of thrombectomy?
Yeah, that's a great question. So that's where I think the collateral imaging comes in that I alluded to in my first talk, that if you've got good collaterals, the 2 hours is going to be fine. We're going to go straight to the cath lab unless there's been a deterioration that could suggest blood or a substantial improvement that could suggest recanalization, right? But if that patient has very poor collaterals, we see a lot of those patients having substantial progression. So we're going to do a quick MRI. That's our approach, is that we can get a quick MRI just as fast as a CTP if we know the exact time the patient's going to arrive. If the paramedics call with a patient unannounced, we can get a CTP much faster.
We do a plain CT after 90 minutes from the CTP. So if the patient had a CTP elsewhere in one of our other hospitals, the patient arrives, get a plain CT. Another thing that I think is pretty cool with the rapid is if you think about Extend that just got published and Wake Up, now we can give thrombolytic for patients up to 24 hours. And this is not on guidelines because it's too new. But if you have a small core and these patients follow these protocols with CTP, we have this everywhere. We don't use MRI for that. Now these patients are thrombolytic candidates. So if they are 2 hours away and they have to travel, you can get thrombolytics on board and get this to help the patient go back exactly to timeless that Greg alluded to that Nima enrolled the first patient. So now again, we went from IV to IA, and now what we learned with thrombectomy is going to help intravenous again. So now we're going to back to the future help in the thrombolytics. So that's pretty cool.
Can you repeat the CT perfusion? Like,
if
you don't have the facility for like acute MRI?
You can definitely repeat the CT perfusion. It's not a problem with that. I mean, these are patients having a big stroke. A little bit of additional radiation or a little bit of additional contrast is not a big deal. We looked very carefully in diffuse to see, do we have any evidence of renal injury? Because we had all these patients getting CT perfusion, some of them getting dual slab, then they go to the cath lab, get a bunch more contrast. There was no hint that we were hurting their kidneys. And one of the AHA guidelines is you don't need to check the creatinine. A stroke patient, just go for it.
Excellent. So 1 p.m. sharp, guys. If you're not here, we're going to close the door. Thank you, guys.